You have been... بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening everybody. Today we have Pathology MOOC 3. It will be one of the most amazing MOOCs. You will surprise from the level today. يلا دكتور مراد, you can start.
Good evening, Dr. Salah. Good evening, everybody. I wish we all enjoy this pathology mock, and we can start now. So we have first Widad and Yasmin. Are you ready?
Yes.
Yes. Okay. Great. So our first station. Okay. We have. I'm sorry. Okay. We have a 60-year-old female patient presented at the outpatient clinic with unilateral firm facial swelling, raising the right ear loop. Facial nerve examination was normal. So first question, what's the most probable diagnosis?
Parotid swelling.
Sorry, I didn't hear you.
Parotid swelling.
Okay, which kind of parotid swelling most probable in this case?
Polymorphic adenoma. Benign.
Okay, great. So
Benign
what? Yes, the most common benign. So the most probable is a benign parotid tumor. The next question will be, what's the most common benign parotid neoplasm?
Polymorphic adenoma.
Okay, great. Can you tell me the differential diagnosis of a unilateral parotid swelling?
That's
It
one.
could be due to, this is due to local causes, either due to ductal obstruction, like in salivary calculus, or external ductal compression from outside, or could be neoplasia, either benign or malignant, or could be infection like mumps or parotitis.
Okay, great. So we can do it this way. Every one of you answer a question, okay?
Okay.
Okay.
So the next question, what's the meaning of pleomorphic?
It's has the remarkable histological derivative.
You have another definition?
This answer not accepted. This answer not accepted.
Yes, we have another definition.
Mixes the histological derivative. Or, yeah.
Variety of histological features reflecting stromal and epithelial elements.
Okay, yes.
Repeat it again.
Yes, but can you say it again, please?
Variety of
last one.
histological features reflecting stromal and epithelial elements.
Okay.
Write
Yes.
it. Please write it in the group.
What are you saying, Dr. Salah?
Please, I asked her to write it in the group. Okay.
Yes, it's okay.
This is the only
So,
answer accepted. Not
yes.
the answer in our book.
Yes. So it's pleomorphic. It's a variety of histological features reflecting both stromal and epithelial elements. Okay. So our next question, can you please describe pleomorphic adenoma appearance?
Yeah, appear a benign tumor consists mixed ductal epithelial and myoepithelial cells, which show epithelial and mesenchymal differentiation.
Okay, that's right. Thank you. Next question. Can pleomorphic adenoma turn malignant?
Yes,
Okay, can you please elaborate more?
it can occur about in 5% of cases.
Okay,
In the case name, carcinoma X pleomorphic adenoma.
okay, great. And do you know any mechanism of this transformation?
Dysplasia leading to a carcinoma formation due to
Okay,
dysplasia.
So the etiology is not clearly understood, but there is many theories like accumulation of genetic alterations like this, okay? And okay, we will share it in the group, the exact answer. Okay, so From your examination, what clinical signs would make you suspect malignant transformation in a parotid swelling?
First affected seven cranial nerve affected, and the presence of the secondary lymph node, and rapid increasing of size or fixation in underlying tissue, involved the skin involvement or fixed to the skin or skin alteration.
Okay, that's right. So next question. What are the characters of a malignant neoplasm in general?
Invasion locally and distal metastasis, rapid growth, and loss of differentiation, and neurovascular invasion.
Invasion in general.
Yes, invasion in general.
Yes. Okay. Can you please tell me a sample test in the clinic to help you differentiate between malignant and benign tumors?
Fine needle aspiration cytology.
Okay. What are the cytological features that would raise concerns of malignancy in fine needle aspiration?
Pleomorphism, abundant mitosis, hyperchromatism, necrosis or hemorrhage, invasion of basement membrane, and also different cytological nuclear mismatch.
Yes, great, that's right.
She
Okay.
mixed it. She mixed it. She mixed it.
No, she said again, she said,
No, she gave the answer. He's asking you cytological features, not histological features. Histological features like invasion of basement membrane, neurovascular invasion. Cytological features like we discussed before. Increase in necrosis, polymorphism, increase nuclear cytoplasmic ratio, like this way.
So again, the cytological features: increased mitotic figures, abnormal mitosis, pleomorphism, hyperchromatism, and increased nuclear cytoplasmic ratio. This is the cytological features. Okay?
Okay.
Because in cytology, we can't see the basement membrane. Okay. So what are the main differences between cytology and histology, and what are the advantages of each one?
Cytology is a study of cells only, without the background tissue. And histology can have a study of cells and surrounding tissue. And advantage of cytology is simple, easy, cheap.
Okay,
but
I am sorry to interrupt. Can you please tell me again the definition of histology?
Histology is a study of the cell and the surrounding tissue and surrounding connective tissue.
Yes, so it's a study of solid tissue.
Yes.
With local connective tissue and the background parenchyma. Okay, so can you please tell me what are the advantages of cytology?
Cytology is simple, easy, cheap, and no need experience, but without
And the
staff
quick.
and the cookies.
Yes. What about histology?
Histology have more accurate study, have the can identify the cells and the connective tissue surrounding invasion, basement membrane. And
so yes, so it's more reliable, okay,
yes.
and avoids unnecessary excisional biopsies, okay, and
Yes.
we can use it to do grading and typing of the tumor.
Yes.
Okay, so we have the next question. Okay. Wait a moment, please. Okay. Can you please interpret these FNA results? If you find Langerhans giant cells, lymphocytes, and necrotic material, what would you suspect?
This is tuberculous granuloma.
Yes. If you found brown pigmented cells, and epithelioid cells.
malignant myeloma.
Okay, great.
Bizarre shaped cell.
Sorry, what are you saying?
With bizarre shaped cells. This
Okay.
picture.
But there is no picture.
Yes.
Don't say anything that you wasn't told, please.
Yes.
Read Sternberg cells, lymphoid cells, and blast cells.
This is Hodgkin lymphoma.
Okay. FNA has a sensitivity of about 81% and a specificity of around 98%. Can you please tell me what the meaning of sensitivity, high sensitivity, specificity, and the high specificity? So we start with sensitivity.
Sensitivity is the test to true positive test, and the sensitivity true positive true positive test and the general population. And high sensitivity.
You mean that yes, it's the ability of the test to identify someone as disease positive or having the disease. So it's a true positive rate. Yes. And what is the meaning of high sensitivity?
It's the low number of the false negative result.
Okay. Now specificity.
Specificity in ability to test to identify the person who have disease free.
Yes. So it's a true negative rate.
Yes, true negative
Yes.
rate.
Yes. And what's the meaning of a high specificity test?
Is the low number of the tests can false positive test.
So high specificity is a low number of false positives. Okay, great. How can you differentiate between carcinoma and lymphoma?
By immunohistochemistry.
Okay. Can you please tell me what's the meaning of immunohistochemistry? How it's done?
It is the pathological test done to the tissue to differentiate. It acts on antigen antibody reaction. Antibody was labeled to enzyme or dye. When it's combined with antigen, this dye will release and activate it and can be shown under microscope.
Yes, that's right. So it's a test done to localize specific antigens. Okay, this is the start of the definition. Okay, great. How to rule out malignancy intraoperative?
Frozen section.
Can you please explain it in simple words?
If frozen and cutting, fixation and assist.
Yes.
And, okay.
Yes. So it's 4 steps: snap freezing, cutting, fixation, and staining. Then we assessed, as you said. Great. So while doing FNA, a needle stick injury was encountered. What would you do?
First, I will allow bleeding from the wound and the running water. And for the patient, I will ask about risk of bloodborne disease, and I will take sample for testing for this blood. For the health worker itself, I can take blood sample for testing of the blood. I will notify the infection control units, and I will follow the results, and I will document the incidents.
Yes, great. So you said it perfectly, but just remember to say I will take a sample from the patient after consenting the patient. It's very important to say consent. Okay.
Okay.
Okay. What are the post-operative complications of parotidectomy?
Nerve injury like cranial nerve injury, great auricular nerve injury, Frey syndrome, and salivary gland fistula.
Okay. Can you please tell me what's the meaning of Frey syndrome?
It is gustatory sweating happen postoperatively, due to facial can cause sweating and flushing of facial sweating and flushing due to reinnervation of postganglionic of sweat glands and cutaneous blood vessels.
Okay. So it occurs due to injury to the auriculotemporal nerve, and this happens after this. Okay. Great. So the patient 10 years after surgery presented with a neck swelling. What could be your differential diagnosis?
Recurrent of disease, lymphoma, mucoepidermoid carcinoma, or lymphatic enlargence. Okay, يعني lymph reaction infection.
Okay, can you please repeat it again?
The first recurrent.
Okay.
The
Carcinoma in general, carcinoma. Okay, so recurrence or new carcinoma. Okay. What else?
Callous body tumor.
Yes, or lymphoma. Okay, so great. This was the end of our station, and I think you did both well. Okay. Dr. Salah, do you have any comments?
No, I shared for them in the notes group. The most important thing is about difference, definition, advantage, disadvantage between cytology and histology, and histological and cytological appearance for any malignancy. I shared already.
Yes, yes.
Also,
and
definition of polymorphism or polymorphic adenoma.
yes.
Okay. It will be accepted. Polymorphic adenoma, they want 3 component, a variable diversity with 3 component, which are epithelial, myoepithelial, and mesenchymal. They are waiting these words. Okay. Other than this, they are doing great. By the way, I know. They did great. Yasmin. She's muted.
I didn't mute anyone.
نعم.
تعرفي تمثلي؟
أنا
زيي انا ما بعرفش بس.
لا بس it's very important. يعني appear to be astonished or when the question is asked to you يعني appear like you didn't see it before and you are thinking about the answer.
Listen for مراد what he's telling you. اوكي. اديلهم الكومنتات بتاعتهم حتى في البرفورمانس مفيش مشكله. بالظبط كده. شوف ساعات بيقول لك ايه؟ لو لقطوها تتسوح. يعني if they will discover that you are keeping the answer rapidly, no, I try to think in front of him, try to act. Otherwise, whatever your study, whatever your preparation, you will not clear this exam. These people, they are very upset if you will do like you are keeping all the station and all the questions.
وطبعا it's يعني كارثة if you told something you haven't been asked about. يعني this will be a catastrophe يعني.
داخل يقول لك انا يوم كذا وانا يوم كذا يا اخوانا. اقول لكم ازاي يعني. طيب اقول لكم على حاجه مهمه جدا. The previous station discussed now with Dr. Murad was the station of Dr. Suzanne in البحرين. Do you think about high sensitivity and high specificity anybody can give this answer? حد يتخيل ان this will be the answer? No.
For the first time of course not يعني.
You know it because of the checklist. When I told this from the checklist. Okay. So what happened? I will tell you what happened exactly in with Suzanne. She answered high specificity and high sensitivity. The examiner looked to her and looked to the paper. He thinking at the beginning that Suzanne, she gets the answer from the paper. He looked to her and he told her, how you know this answer? He told her, you are the only one who answered this question. How you know this answer? طبعا عارفين your mom مش سهلة خالص. She said to him, because I have many researches in statistics, so I know this. She said, you have researches in statistics? She said, yes. So I know this answer. It's amazing, excellent.
Alhamdulillah, no, he didn't ask here more questions about
I think
statistics.
this session will come for you and you will answer high sensitivity and specificity simply by this way. 100% you will discover that you know the answer, you know the questions. مثل بالله عليكم ما ينفعش. Cairo exam became different by this way. Okay. Yeah, next.
Great. So now we have Mustafa and Nazneen. So please raise your hands. Okay, Mustafa.
Nusrat Mustafa.
But is different station, I think. Hello, Assalamu alaikum.
Assalamu alaikum, sir.
عليكم السلام.
ما فيش حاجة اسمها different station.
Okay. You know, I haven't the time.
Forget about this يعني.
Yeah, okay.
هو أصلا أنا مش عامل أي order يعني. يلا. Okay, so are you ready?
Inshallah.
Inshallah, great. So a 55-year-old female with mastectomy done 5 years back and parotidectomy for a pleomorphic adenoma. Can you please tell me what happened? Okay. What is the relation between breast cancer and the pleomorphic adenoma?
Base gene with the breast and salivary gland gene.
Yes. And as Dr. Salah said, I think there is a genetic relationship between them, maybe base gene. Don't say directly base gene. It's very hard to know it because I have searched in the papers for so long to find this one. And you can say also, and probably BRCA 1 and BRCA 2, if he kept asking, because it's written also in many papers. Okay.
Yes, we told this yesterday, me and Maria yesterday. We told them about you should make
the three actually, Dr. Salah, are right.
صح بس هو كان بيسمع base gene and ask in another center I think what others base gene, so tell him base gene BRCA 1 BRCA 2.
Yes, so
and they are sharing the same morphological.
Yes, you are right. Great, you're great. If he kept asking, say this one. Yes, this right. Some of the breast cancers share some histological and morphological features of salivary tumor. Yes, great. You know this. Okay. Next question. How would you investigate a clinically suspected pleomorphic adenoma in the clinic?
For me or Dr. Nazin? I continue?
Dr. Nazin. She can answer. يعني every one of you answer a question.
Yes, it is for FNAC and TrueCut biopsy.
Yes. Or okay. Can you tell me, Mustafa, what are the advantages of an FNA over a TrueCut biopsy? Tell me the advantages and disadvantages of each one.
So FNAC, it is simple, easy, and cheap. Okay.
And quick.
And quick also. And the disadvantage and accurate, maybe inadequate sample. And the opposite side, TrueCut biopsy, it is more expensive but more accurate. Yeah.
Yes, it's more expensive, more invasive, okay, and it may leave a score.
Yes.
Okay, and painful to the patient, of course. What tests can be done in FNAC?
Immunohistochemistry, receptor status.
Okay. Can you please tell me again what's the meaning of pleomorphism in general and describe pleomorphic adenoma appearance?
Pleomorphic or polymorphism, it is a change in the size and the shape of the cell.
Yes, so yes, this is a general term. So describe pleomorphic. What is the meaning of pleomorphic adenoma in general? in this case? What does it mean? We said that in the last
va-
station.
Variety of histological feature reflecting both stromal and epithelial components.
And the myoepithelial, as Dr. Salah said. Okay, so could pleomorphic adenoma turn malignant?
Yes.
Yes, and in about how many? In 5% of cases, and it's called,
Carcinoma X pleomorphic adenoma.
okay. After 10 years from resection, the patient developed an X swelling. What could be your differential diagnosis?
So it is maybe recurrence or new carcinoma or lymphoma, lymph node enlargement, carotid body tumor.
Okay, great. If metastasis erodes the carotid artery, why it would not stop bleeding?
Because of the high blood flow and the tumor invades the arterial wall, so the artery loses its ability to vasoconstrict. Also could be due to the cancer is itself a hypercoagulable state. Also could be due to liver metastasis and affection of the clotting factors 2, 7, 9, 10.
Okay, so I would agree with the necrotic arterial wall cannot sustain the high pressure. Okay,
And the high
this
blood
is
flow.
right. Okay,
High flow, yeah. And the high flow.
yes, the arterial wall itself, it would be necrotic for many reasons, and this, but there is no hypercoagulable. If there is hypercoagulable state, it will
Stops.
stop bleeding.
Mm.
Okay, so don't mention
Okay.
hypercoagulable state. Okay,
Okay.
and by the way, for your knowledge, if anyone asks you, it's common, it's called carotid blowout syndrome. The carotid artery ruptures, okay, from
Okay.
cancer. It's called carotid blowout. Okay. Can you define a metastasis?
It is survival and spread of the tumor cell away from the original tumor, primary tumor.
Okay. It's a survival and the growth of
The growth.
cells. Okay. Can you list 5 steps by which metastasis occurs?
Direct or continuous extension, penetration into surrounding lymphatics, blood vessel, and body cavities, transport of the tumor cells into the circulation, arrest of in the capillary of the secondary sites, and growth of the disseminated tumor cells in the secondary site.
Great. What are the main routes of spread of malignancy in general?
Direct spread, transcelomic or transcavity through the blood vessel, vascular or lymphatic spread.
Okay, great. And by the way, there are other routes. How does lymphatic spread occur?
The cancer cells and the tumor-associated macrophages secrete growth factors such as
Please. How does it occur? I didn't ask about the mechanism. Yes. How does it occur in general?
Via permeation and embolization.
Okay. What are the mechanisms by which cancer cells promote lymphatic spread?
So cancer, yeah, you can go, yeah.
The cancer cells and the tumor-associated cell macrophages secrete growth factors such as vasculoendothelial growth factors C and D. This promotes lymphangiogenesis in the primary tumor and the draining sentinel lymph node, and also the primary tumor release immunomodulatory molecules such as exosome, which promote immunosuppression.
Yes, great. So this was the end of our station. And thank you both. You did very well. Okay.
Thank
you. Dr. Salah.
Yes.
I think they did great, yeah.
Yes, I know. I want to repeat again why carotid bleeding won't stop. The big for them.
دكتور صلاح، انا بقى عندي كومنت لان انا درست الموضوع ده يعني. هو غالبا مش ميتاستاسيس مش هتخليه ستوب، لا ده هو بيبقى غالبا حصل perforation and it won't stop bleeding because عشان اللي هقولها تاني ان الارتيريال وول بيبقى نيكروتيك خلاص and can't sustain the high pressure in the carotid. And there is more explanation ان هو بيبقى غالبا بيحصل له النيكروزس ده او الاسكيميا يا اما from radiotherapy على هي from tumor itself or from radiotherapy or after surgery. بس يعني انا ما عندي، بس طبعا ما فيش hyper coagulable state يعني it's not right يعني.
We answered all this answer not accepted except carotid blowout syndrome which is a fatal hemorrhagic.
I said carotid blowout syndrome.
هي دي اللي عشان كده عايزك تعيدها لهم، انا كده قلت لك عيدها لهم تاني.
Okay, so it's called carotid blowout syndrome. It occurs mainly it may occur spontaneous or after irradiation or carotid surgery. And why is that? Because after surgery they do stripping of the carotid sheath itself, and this weakens the blood supply to the carotid artery and causes ischemia and weakness, so the carotid artery will rupture. I hope it's clear now.
So you will start your answer by this way, plus you will add all other things like hypercoagulability, anything you can add. But
هو يعني if we said carotid blowout syndrome this will sound يعني great يعني.
I know this is the answer.
اوكي.
جبتها منين ديت؟ جبتها منين وجبتها لي؟
ايوه يا باشا انا بدخل اقرا كل البيبرز على الكلام ده.
ما كتبتهاش له ليه بقى السؤال ده؟ ما كتبتوش له ليه؟ ما كتبتوش ليه؟
مكتوب عندي بس يعني ما احنا ما قلنا بقى عشان بقى يفكروا يعني.
تمام يلا.
And we have additional questions really when to judge that the specimen is adequate, when it's not adequate. I know you have these questions.
انا هقول لك السؤال ده انا وصلت له ازاي. يعني I know this question asked and all candidates دكتور صلاح they are not accepting our answer.
لان هو الكويشن بيتقال غلط، يعني اللي بينقل لك الكويشن he didn't say it right.
I shared for you what is the carotid blowout syndrome. I shared for you what is this. I hope it's clear now. يلا next.
Okay, so we have next we have عبد الرحمن الجيزاوي ونورهان. Okay, so
طب استنى معلش، استنى بقى، انت فينك يا نوبة؟ I shared in the notes group but I found now Nuba she shared it for me. I will read what is Nuba shared exactly about carotid body syndrome, carotid blowout syndrome. Blowout syndrome. If the mets erodes the carotid artery, why would not it stop bleeding? Number one, carotid blowout syndrome rupture could occur due to necrosis of arterial wall as a result of direct tumor invasion. Rupture could also occur following resection of the neck tumor.
ما زي ما قلت لك.
Number two, increased pressure in the carotid artery. Number three, tumor invading the arterial wall, so leading to erosion of the wall and affecting the ability of artery to do vasoconstriction and response to stop the bleeding. Number four, hypercoagulability or coagulability. خلاص؟
كل الكلام ده رايت، بس هايبر كواجيولابيلتي دي غلط. هايبر كواجيولابيلتي
ما هو بص، لو عنده البيشنت كانسر وعنده هايبر كواجولابيلتي البليدنج مش هتوقف بسهوله. يعني الكلام ده مش غلط.
هو هايبر كواجيولابيلتي يعني البلاد بيكواجيوليت زياده.
You can take coagulopathy.
ايوه بالظبط. You can say coagulopathy. Yes. Okay, so now we have عبد الرحمن الجيزاوي ونورهان. Raise your hands please. عبد الرحمن الجيزاوي.
تتخيل اللجنه دي تجي لهم كده في القاهره
اهو نورهان.
يدخل سعيد وبعدين نورهان وبعدين عبد الرحمن يقولوا له ايه على طول؟ كاروتيد بلو اوت سندروم. يبقى خلاص ما هي باينه.
يعني we must يعني نأكت شويه. I think it's okay maybe and we can say the answer because of erosion of the tumor, the wall of the artery. I think this is called carotid blowout
syndrome. I think
like this.
carotid subsync carotid blow. هاتها كده.
Yes.
عبيط.
يا رب يا رب يا باشا افتكرها، بس افتكر اسمها يعني هي دي المشكله.
يا ريتك ما تفتكرها. كل صلاح. ايوه اكسلنت. ودونا في داهيه. ودونا في داهيه.
يعني ايه هقعد افتكر دكتور صلاح قال لي ايه وساعتها هنسى كل حاجه.
انت متخيل؟ could you imagine in Cairo؟ انت عارف احنا معانا كام واحد في القاهره؟ we have now around 120. they are 200. they are 200 going for the exam in Cairo. we have more than 120. 120 person will come for half of them.
ما عشان كده يا باشا احنا استخدمنا ذكائنا ورحنا البحرين.
قلت لك كاروتيد بلو اوت سندروم. كاروتيد بلو اوت سندروم. ماسي.
يعني
I think I heard about a syndrome which is a complication of malignancy or radiation. I think it called the carotid blowout. He will tell yes amazing. مثل كده بالله عليك.
يعني personalize your answer.
طيب انا كمان قاعدين نبص قاعد كده. انا مثلا ايروجن وكذا كاروتيد بلو سندروم. نعم.
يعني حتى انت كده بتحبطه يعني بتحبط.
والله العظيم انت بتهزر. يعني لذلك ايه؟ كاروتيد بلو سندروم. نعم. ليه يعني؟ ليه؟ مين انت؟ اينشتاين؟ نيوتن؟ يعني عارف كل حاجه في العالم؟
الراجل حتى يجي له احباط يعني.
هات اخرك يا انجليزي. هات اخرك. صح علينا كل حاجه.
Okay. So we have station 3. Are you ready?
Yes sir.
Yes.
Okay. Welcome. So we have a lady known to have ulcerative colitis, and on surveillance colonoscopy, she's found to have a lesion less than 1 centimeter in sigmoid colon. Now, can you please tell me what's ulcerative colitis?
It is a chronic inflammatory bowel disease affecting the colon in the form of colitis with characteristic ulcers.
Okay. Do you have any other definition, a more detailed one?
Yes, it's a chronic inflammatory disease involving the wall and part of the colon, characterized by inflammatory processes involving the mucosa.
Yes, and always, nearly always, it involves or starts in the rectum.
Right.
This is very important. Okay. What is the etiology of ulcerative colitis?
It's almost idiopathic.
Yes, but do you know some suggested theories?
It's maybe immunological, environmental, or genetic.
Yes, great. Can you tell me what's the commonest site for ulcerative colitis?
Colon.
Yes, especially the rectum. The rectum is the commonest site. Okay.
Okay.
Do you know what is the meaning of backwash ileitis?
Yes, it is the involvement of the terminal ileum, which occurs in the long-standing cases of ulcerative colitis. The inflammation will be continuous with the cecum with no skip lesions.
Yes, great. So in long-standing cases, there will be inflammation of the entire colon and will extend into the ileums, as you said. Great. What treatment would you offer this lady and why?
Proctocolectomy, because it's 100% will lead to cancer colon.
Yes, so we will do proctocolectomy with either end ileostomy or we can make EVA. Yes, great. If there is liver mets, how will this affect your TNM staging?
It is going to be M1.
Okay, this is right. What is the microscopic features of ulcerative colitis?
In acute stage and chronic stage.
Sorry, I am not hearing you. Can you please raise your voice?
Okay. Histologically, it may have crypt abscess, inflammatory cells in the lamina propria.
Okay, so this is the most important. This is the most important. Okay.
Okay. Okay.
So how does this differs from Crohn's? What are the microscopic features of Crohn's?
Crohn's have granulomas and non-caseating granuloma.
Yes, non-caseating epithelioid cell granulomas. Yes, perfect. With Langerhans giant cells. Yes. Okay. What would you see on colonoscopy in ulcerative colitis and in Crohn's?
Excuse me?
Colonoscopy. You have done
Oh,
colonoscopy.
okay.
What do you expect to see in ulcerative colitis and in Crohn's?
Okay, in ulcerative colitis, I will see pseudopolyps and extensive ulceration, bleeding.
Yes.
While Crohn's, it is significant with the cobblestone appearance by having skip lesions, aphthoid ulceration, linear fissures, and creeping fat.
Yes, I doubt that creeping fat will be visible with colonoscopy. Okay, you can see it from the colonoscopy. Okay. What's the prominent clinical features of ulcerative colitis and what are its complications? What does the patient have?
Colicky abdominal pains.
Yes.
Diarrhea and tenesmus. As for the complications, the patient may have malabsorption, megacolon, toxic megacolon, gallstones, malignancy.
Yes, malignant transformation, right?
Intestinal obstruction.
Yes.
However, I doubt intestinal obstruction and fistula formation are more common in Crohn's.
Yes, they are not. Yes, they are common in Crohn's disease. Stricture and ulcer and obstruction more common in Crohn's, not in ulcerative colitis.
Yes.
So the prominent, as you said, colicky abdominal pains, diarrhea, tenesmus, bleeding rectum, like this. Okay. And the complications, as you said, toxic megacolon, there may be abscess formation, malignant transformation is very important. Okay. So why does this patient have diarrhea?
I think this patient has the, I'm sorry for interrupting.
At this point, the clinical features of ulcerative colitis, at this point, you can add also extraintestinal features. But we will ask about them later, but you can say them because they are part of the clinical picture. Okay, so I'm sorry, go on. Why does the patient have diarrhea?
After the patient underwent the terminal ileal resection?
Before
the terminal ileal resection, the patient has malabsorption, infection, and increased motility.
Okay, so the patient now underwent terminal ileal resection, but still has diarrhea. Why?
Maybe the patient has recurrence or malabsorption, steatorrhea, and maybe short bowel syndrome.
Okay. Why are patients with Crohn's are more susceptible to renal stones?
Due to increase the intestinal fats due to malabsorption. These fats will bind to calcium and therefore leaving the oxalate and forming hyperoxaluria.
Yes. Besides the GIT manifestations, what are the other systems that could be affected by inflammatory bowel diseases in general?
Generally, other systems that could be affected, like the joints, having seronegative arthropathy. The kidneys, they can develop calculi or stones. Liver can have cirrhosis or cholangiocarcinoma. In the eyes,
And also, I'm sorry, sclerosing cholangitis, very important.
okay.
Okay, continue.
The eye can have conjunctivitis and episcleritis, and the patient generally can develop clubbing, DVT, pulmonary embolism, and erythema nodosum.
Yes, and the bioderma skin manifestations, very important. Bioderma gangrenosum. Okay, thank you. How would you investigate a patient with suspected ulcerative colitis?
Stool analysis. We will find occult blood and stool.
Raise your voice.
Stool analysis, occult barium through, follow through.
So classify, always classify or die. So say laboratory tests first, what we do.
Okay. As for the laboratory tests, we may have a full blood count.
Yes.
We may see macrocytic anemia or iron deficiency anemia due to bleeding. As for prothrombin concentration due to vitamin K deficiency.
What? Sorry, I'm sorry. Why macrocytic anemia?
It's part of the blood extra manifestations of Crohn's.
Why? Okay, so continue.
Vitamin B12 deficiency.
Yes, right.
Yes.
Be prepared to be asked like this in the exam. So urea and electrolytes, what else?
Stool analysis.
Yes. What are you looking at the stool analysis?
Occult blood and stool.
Yes.
And calprotectin.
Calprotectin. Okay. And we may do microscopy for any infections. Okay, so lab tests. What else?
Radiological tests.
Okay, like
barium follow through, CT scan, or X-ray.
Yes, so we always start with X-ray.
X-ray, okay.
Yes,
barium
contrast.
follow through, and then CT
yes.
scan.
Okay. And we may do colonoscopy. It's the most important. We do colonoscopy and biopsy, but not in the acute stage. Okay?
Okay.
Sorry, I wanted to interrupt. I think the discussion is amazing, so I stopped. انت جراح بس انا عايز اقول حاجه. Regarding of occult blood, asked in this station in history taking, and the examiner was waiting occult blood.
Okay. It's very, yes, it's very
So,
important. She said.
عرفتها. في الاخر stool analysis. Okay, so don't forget occult blood. This number one. Number two, I want to tell you the best way in discussion, in history, and in examination, according to Shinoda. Shinoda talked to me before, and he told me, Salah, examiner they like what? When you are coming for management in general, you will tell we have in management conservative management, surgical management. Surgical management, two parties, less invasive and more invasive. Like what? Knee osteoarthritis. Conservative, physiotherapy, exercise, decreasing weight, non-steroidal anti-inflammatory, steroid injection. This is a conservative. Less invasive, like arthroscopic surgery. More invasive, like total knee replacement. Say like that. Also, in investigations, you will tell, okay, I will divide investigations. Tell the example, I will divide investigations into laboratory investigations, imaging, less invasive and invasive. Less invasive like X-ray, ultrasound, CT. Invasive like CT with contrast, like colonoscopy. They like titles like this and divided by this is the way.
Yes.
I like it. I like it.
يا باشا هما they say classify or die. يعني anything classify عشان حتى even for the time sake for يعني لو قالت الكلاسيفيكيشن ده حتى لو ما لحقتش هو he knows that she understands يعني.
You will get professionalism marks by this way.
Yes. So, what are the vitamin deficiencies to be expected in inflammatory bowel disease?
Vitamin A, D, E, and K.
Yes, and what
And
else?
vitamin B12 and Crohn's disease.
Yes, especially in Crohn's disease because of the terminal ileitis.
Exactly.
Yes. Okay, so does this patient needs endoscopic surveillance and why?
Yes, this patient needs microscopic surveillance because it will develop cancer.
Yes. The risk of cancer increases, especially after 10 years by 1% every year. This is general information because they are asking many questions now. Okay, how would you treat a patient with Crohn's disease? And remember what Dr. Salah said now.
Okay. Medical treatment.
Yes,
Medical treatment. Medically. Let's start with lifestyle modification.
yes,
Low residual diet, low fat diet, low alcohol,
okay,
high fibers. Then medical treatment. After discussing with a gastroenterologist, maybe steroid, antibiotics if there is infection, immunomodulators if not responding or refractory cases, salicylic acid, and
5-amino salicylic acid, okay, or mesalazine,
Okay.
yes,
okay, and surgery, more invasive surgery. If the patient is refractory or develop complications as intestinal obstruction, toxic megacolon.
we are talking
For this
now,
patient,
yes,
we're talking about ulcerative colitis, so toxic megacolon.
Crohn's. We are talking
or-
about treatment of Crohn's now.
Okay, so fistula, intestinal obstruction, perforation, or malignant transformation.
Okay, so you said right, but to recap, so the treatment of, you have to say the treatment of Crohn's disease is mainly medical, as you said, lifestyle modifications. Then we have the drugs like 5-amino salicylic acid, steroids, immunomodulators like infliximab, okay? Then we have surgery, which is indicated in refractory cases or in developed complications, okay? And mostly we do limited resections of the intestine, okay?
Okay.
Great. What are the indications of surgery? You said that, okay, so complicated or refractory or complicated cases, like you said, development of fistula, toxic megacolon, all of this, okay, and control the bleeding, fulminant infection. Okay, what's what's TNF?
Tumor necrosis factor.
Okay.
It is a pro-inflammatory cytokine,
Yes.
which is involved in systemic inflammations.
Okay. Can you tell me some of the functions of tumor necrosis factor?
It activates macrophages and neutrophils. It acts as a stimulator for T cells, and
Yes,
it's
great.
it has anti-tumor effect.
Yes, perfect. Okay, and in inflammatory bowel disease, what's its role?
I think its role in direct epithelial role in increasing the tight junctions permeability,
Yes,
which
great.
increasing the flux of luminal bacterial components, which activates innate and adaptive immunity.
Yes, great. Perfect answer. Okay. Can you tell me which drugs antagonize tumor necrosis factor?
خلاص جاوبين.
Infliximab.
عزموا على
infleximab,
بعض بأسئلة. اوكي.
infleximab and sertolizumab.
Yes, and adalimumab. Okay. What's the mechanism of action of tumor necrosis factor? Sorry, of anti-tumor necrosis factor drugs.
Monoclonal antibody
Yes,
to tumor necrosis.
yes, immunoglobulin G. So they are monoclonal antibodies. Their type is immunoglobulin G. And when do we use them?
In refractory cases.
and
Okay.
if there is extra intestinal
Manifestations.
Yes, and they are called biologics. Great, thank you very much. You did very well. Okay.
thank you.
You're welcome. Dr. Salah.
النبي ما تسأل أي حاجة تاني.
حاضر. لا 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 ما مش
لسه عندي لسه عندي.
خد بالك انا حاطط بقيه اسئله اللي هي الباقي دي انا حاططها مع لجنه ثانيه بس عشان
الحمد لله ده ستيشن طويلة جدا. أنا كنت عامل حسابي على حاجة صغيرة.
لا 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 السيشن ده طويل، وفي كمان حاجه ثانيه ما حطيناش في الموك. اوكي. I will stop sharing. انتوا معايا؟ الملف ده كانت مذاكرتي. المذاكره كنت بذاكرها مع نفسي قبل ما اروح الامتحان. اوكي. So where is the pen؟ حط القلم فين؟
حضرتك قصدك الصور اللي هي بتاعت الكرونز.
استنى هشيرها تاني.
يا
ايوه
باشا دي انا بسيبها لك كده تشيرها انت.
اوكي. تمام كده واضحه الصوره؟
زي الفل.
Okay, you will find first about Helicobacter pylori. By the way, this station came by this way in one exam before. So try to read them. Try to read the story. We will not discuss it, but this since a long time came by this way and will be discussed. Will be discussed also. Okay, aortic stenosis causes and Crohn's disease. This station came in البحرين before Corona. Then came in Cairo. When came in Cairo, most of candidates they can't answer it. ده وانا بذاكر على فكره. This during my study because they don't know what is the problem in this station or what is going. So I get the questions from Bahrain. يعني came before in Cairo. Came once in Cairo. Came once in Cairo. Young male with abdominal pain, blood diarrhea, operated resection anastomosis done with this picture of a specimen, and shows him these pictures. The specimen, like my friend told me, he told me exactly. They brought Salah a small bowel, and it's filled with rice, like filled with rice. I think he's meaning this picture.
Cobblestone.
He meant he told him he's told it's a picture filled with rice, like with rice, محشية رز, like this or this. So examiner asked what this was. The question asked in this station. What is the? It was a small bowel. Which part of small bowel? Terminal ileum or cecum? And I think show him the appendix. I'm not sure about appendix. Which picture for the appendix? And asked what is the abnormality? You will tell it's altered or obstruction of the terminal ileum or in the small bowel. Then asked what is the features of Crohn's? What is the features of Crohn's according to the picture? So you will tell there is couple stoning, this one, and he told show me in the picture. Couple stoning, linear
fissures, linear fissures.
You can see it here, and this is fat. This is a creeping fat. He's asking to show him the features of Crohn's in the pictures. Okay, so you have couple stone appearance, you have skip lesions, you have fistula, you have also non-casetic granuloma. Then asking about features of ulcerative colitis, then extraintestinal manifestations like we discussed, then the station going exactly discussed now.
أنا بس دكتور صلاح I have only one comment إن إحنا when we are telling the clinical features of Crohn's please remember anorectal complications, anorectal disease. They are very common in Crohn's. طبعا يعني I'm working as a colorectal registrar. That's why يعني أنا إيه مركز على الحاجات دي. Okay, so I will start sharing my screen now. وربنا يستر.
ليه؟
اوكي.
آه،
شغاله؟
تعرف ان الدكتور عبد الرحمن زوج الدكتوره نورهان؟
ايه ده؟ نو.
This both of them they called me when they was engaged before in part A before the exam by 1 month. Abdurrahman he called me, we want to join your course. I said, what you will do in 1 month? You will not pass. No, we are late, but we will join. Now exam is difficult. I almost finished from recalls. They joined within 1 month. Both of them pass.
ما شاء الله.
Pass. When I talked to Abdurrahman, I asked about the score. Abdurrahman, alhamdulillah, almost passed, like all male, like us, like all of us. And Dr. Nuhan, she scored about 84 or 85.
ما شاء الله.
They are saving their money that time for marriage. So they joined only the crash course. If I know that they will do that, كنت بلغت عنكم السيس والله. في صندوق روحوا ادفعوا له.
يلا.
So
Okay.
You pass it together when you are engaged, and for sure, inshallah, you can do it, inshallah.
They are great صراحة. Okay, so next we have Mark and Haifa Fauzi, I think, if I'm right, yeah. Haifa, yes. Ask to unmute. Then we have Mark. Okay. Okay. Are you ready?
Hello.
Yes.
Hello. Hi, Mark.
Hi. You okay?
Okay, great. And we have Haifa. Am I
Yes.
right? Is it Haifa?
Yes, Haifa.
Okay, perfect. So we are starting now. You are discussing the results of a follow-up colonoscopy with a young lady with endometriosis. She was very concerned because her father died of colon cancer at a very young age. So, what can you see in this colonoscopy image?
I think there's multiple polyps with some ulceration.
Okay, what could be the diagnosis? But there is, can you please point to the ulcers?
Can I point? I'm not sure if you can see my cursor.
Yes, but I can't, from my picture, I can't see any ulcers. Maybe you can see something else, but I couldn't find any ulcers.
I think the change, the discoloration, the white aspect gives you an idea that there is some exudate, or I think that would probably be my thinking.
Yes, the colonic secretions, yeah, maybe, but there is mainly multiple polyps. Okay,
Yeah.
different sized polyps. Okay, what's the most probable diagnosis?
Probably familiar adenomatous polypopsis.
Okay, thank you. So can you please, Haifa, define FAP?
Yes, it's an autosomal dominant condition associated with the loss of APC tumor suppressing gene in the long arm of chromosome 5, characterized by the development of hundreds of adenomatous polyps with 100% risk of cancer development by age of 40.
Okay, so again, what is the mode of inheritance of FAP?
It's autosomal dominant.
Okay, great. Can you tell me what's the function of ABC gene?
It encodes a factor that downregulates the WNT pathway.
Yes, negatively regulates. Yes, you're right.
Yeah, negative regulates.
Yes,
the
you
WNT
understand it,
pathway.
and you said it right.
Okay.
Okay.
And it stimulates the production of a complex that degrades the beta catenin.
Okay. Yes, this is great. Mark, what's the classification of intestinal polyps?
I think essentially we have three classifications, either neoplasm or non-neoplastic or inflammatory.
Okay.
Obviously with the neoplastic also we have three subclassifications. We have the tubular, the villous, and then the tubular villous types. And then the non-neoplastic, we have hematomatous, and then metaplastic. And then the inflammatory ones would usually be either could be ulcerative colitis or probably Crohn's or something like that. I'm not sure.
Okay. Yes, perfect. It's right. But just for your knowing, in most books, it's only classify them into neoplastic and non-neoplastic, because the inflammatory ones are also non-neoplastic polyps. So you can say non-neoplastic and neoplastic, and then say all the three under the non-neoplastic. We have the hematomatous and the hyperplastic and the inflammatory. Okay.
Okay.
What are their complications of polyps, Haifa?
They may undergo malignant transformation.
Yes.
And they may predispose to intestinal obstruction or volvulus or intussusception. They may be associated with electrolyte imbalance, especially hypokalemia if they are large and confined within the rectum. And they may lead to ulceration and bleeding.
Yes. Perfect. What are the features increasing the risk of malignant change in a polyp? Mark.
I think the size, the diameter, I think increasing diameter would predispose it to malignancy. And then obviously the type, whether is a tubular or villous type.
So can you please classify them according to the risk of malignancy? Which one is associated with a higher risk?
I think the tubulovillus has a higher risk to malignancy.
Actually, it's the villus.
Is the villus, okay.
Yes, followed by the tubulovillus and lastly the tubular.
Okay.
Okay.
And then the diameter, the larger the diameter would predispose to malignancy.
So we have the type, the diameter, and what else?
I can only remember these two.
Yes, the degree of dysplasia itself.
Okay, degree of.
Okay, thank you. Haifa, can you please describe the sequence of events in malignant transformation of adenoma and what is called?
It's a stepwise accumulation of genetic mutations
And
to
it has
oncogenes.
I'm sorry, it has a specific name.
I'm not sure what is it.
Yes, you are defining it rightly, but it's called the adenoma carcinoma sequence. Okay. So go on.
So the adenoma carcinoma sequence is a stepwise accumulation of genetic mutations to oncogenes and tumor suppressor genes. It is first APC tumor suppressor gene loss will lead to hyperplasia, and then followed by the KRAS oncogene mutation leading to dysplasia, and finally the loss of the P53 tumor suppressor gene leading to the development of adenocarcinoma.
Okay, great. Mark, can you please tell me what's a proto-oncogene, oncogene, and tumor suppressor gene means? So first, what's a proto-oncogene?
Proto-oncogene will be proteins that have not undergone any mutation. Essentially, they stop proliferation of cells, and an oncogene will be a mutated proto-oncogene, which results in cancer cells or tumor. And then tumor suppressor genes like P53 and APC tend to play a significant role in DNA repairs and cell growth to stop proliferation of tumor cells.
Okay, so simply, Mark, it's a proto-oncogene. You have to say it's normal. It's a normal gene. It's very important to say it's normal, and it controls cell growth in normal cells.
Okay.
As you said, oncogene is a mutated or overexpressed proto-oncogene, and tumor suppressor genes, as you said, they are genes. When they are absent, they promote the development of cancer. Okay. Okay. Next question. What are the functions of KRAS gene?
Okay. KRAS gene stimulate the production of a protein known as KRAS protein. It stimulates, it promotes the proliferation of cells. It relies signals from outside the cell to the nucleus. It instructs the cells to either differentiate or proliferate. So it acts or serves as a switch. No, it's the KRAS protein, it's a GT-based protein and is activated by binding to either, it converts the GTP molecule to GDP molecule.
Yes.
And acts as a switch by binding to either molecules, ETP or GDP. It is activated or turned on when it is bound or attached to the GTP molecule.
Yes, it's great. You understand. So it's a GT base, which means that it converts GTP to GDP, and it's active when it's bound to GTP and inactive when it's bound to GDP. Okay.
Yes.
Great. So the B53 gene.
The B53 gene has three major functions, which are the growth arrest and the DNA repair and apoptosis as a last resort.
Yes, great. So you can say it's a tumor suppressor gene who has three functions, as you said. Okay. Great. Mark, can you please tell me what do you know about Gardner syndrome?
Oh, this one I've forgotten. Sorry. Haya can probably answer.
Okay, no problem. So Haifa.
Yes, it's a variant of the familial adenomatous polyposis. It is characterized by mandibular osteoma, desmoid tumors, sebaceous cysts, and fungal gastric polyps, along with thyroid and brain tumors.
Yes, and abnormal retinal pigmentation. Yes, perfect.
Okay.
So what treatment would you offer this lady with FAB? You can answer, Mark, if you know.
I think I'll probably give her prophylactic colonectomy.
Yes, colectomy. Yes, by which age?
Before 25.
Yes, by the age of 25, and we can do it earlier if a lesion was detected. But if there is nothing abnormal, we do it at the age of 25. Okay, right. Which lifestyle modifications would be beneficial in reducing cancer risk in patients with FAB?
I'd recommend high fiber diet and limiting alcohol, stopping smoking, and reduce the fat intake.
Yes, great. If she has a two-year-old child, what would be your advice to her?
She should have active surveillance of colonoscopy or by age 12.
Yes, great. Yes, of course, this is a simple answer, but it's more complicated than that. Okay, this is the end of our station. You did very well, but Mark, I know you understand, but you need to know the answer, okay? Much better than, okay? But you did very well, okay?
Thanks.
Thank you. Dr. Salah, do you have any comments?
Yeah, I think this station came before once, and when it came, they asked about the B53, KRAS gene, Gardner syndrome, all the questions asked now, they asked before. came once since a long time. So they will ask about the question by this way. Thanks for Noba. I shared all the message from here about this station. She's making it very simple. So I shared, if you can't understand how CRAS is working, what is B53, from the discussion, go for the notes group. You will find all of this. Don't send for Noba to send for you in private. Noba, don't send for anybody. Because if will be forward, you know what happened in part A before, it will be forward for free groups and will be written by another names. And this is specific for our course. So don't go for Noba and send your notes. Don't worry, she's sending for me and I'm doing forward for you in the group. هيفاء, you are amazing.
Thank you.
انا مش عارف اللي حصل في دبي بس انت عايزه اقول مش هتكلم.
she is
Not sorry.
amazing. وهي she
يعني
understands يعني بصراحة و she understands what she's talking about. يعني هي دي الحاجة المهمة. she knows يعني.
يلا.
Thank you.
Okay. So next we have Saeed Mohammed wa Hussein. Oh, there is another question. I'm sorry, Haifa.
Hi.
Hi, Mark.
Yeah.
What is endometriosis?
Endometriosis should be how do I put this? So the endometrial cells outside the uterus, really. Oh, it's endometriosis.
Yes, so it's a presence of ectopic, okay?
Yeah.
Endometrial tissue outside of the uterus, simply. Okay, thank you, Mark. So now we have Saeed, Mohammed, and Hussam.
I think Mark is doing great every day, but I think this station even difficult for me as orthopedic.
Yes, دي معقدة يعني. أنا بس عشان أنا كله ريكتال فأنا الحاجات دي بالنسبة لي easy يعني، بس هي معقدة فعلا يعني. So we have Saeed and Hussam. So Hussam and where is Saeed? Okay, can't find Saeed. So Hussam, are you here?
Yeah, I'm here. Hi.
Hi. Okay, so we need another one to participate. So please your hand. If anyone wants to participate, raise your hand.
عندك سعيد.
ما هو سعيد، ما احنا عايزين اتنين اللجنة يعني عشان يبقى اللجنة دي طويلة فيبقى معانا حد.
حسام واحد فيهم.
ما هو انا سعيد انا مش لاقيه.
يا عم سعيد شحت قدامك رافع ايده.
طيب ثانية واحدة فين؟
علي معاك احمد كمان ومعاك منصور.
ازيك يا باشا؟
طب حلو جدا زي الفل. اهلا وسهلا. Okay, so are you ready?
Okay. Yes.
Great. So you have a 47-year-old patient with diabetes, hypertension, underwent cholecystectomy for cholecystitis, and at operation, the gallbladder was found to be thickened and adherent to the gallbladder bed in the liver.
Before going for this station, this was my station in Oman exam, and the answers will be done today from the rally checklist. It will be from the rally checklist. تمام? So concentrate. يلا اشتغل.
Okay.
Okay, معاك يا باشا.
So, okay. First question, what's the most probable diagnosis for a thickened fixed gallbladder in this elderly female?
Yes, it is carcinoma of gallbladder. Most probably adenocarcinoma.
Yes, it's a most probably malignancy. We don't know yet, okay, the type of malignancy itself. Okay,
Yes.
What is the main risk factor of this tumor in the UK?
In the UK, the main risk factor is about chronic cholecystitis due to this stone in alcoholic patients.
Yes, it's gallstones. It's most probably chronic calcular cholecystitis. Okay. Can you please tell me what the other risk factors?
For this patient, she's an old age, 74, and also she's female.
Yes, great.
Okay, and there is a history cholecystitis,
Yes.
hypertensive.
Yes, yes, perfect. It's great that you started, even if I asked it about the general, you started with the relevant ones first. So this is great. Outside of this, what are the other risk factors?
Smoking, alcoholic, family history,
yes, yes,
and also obesity.
Yes, and important, gallbladder polyp more than 1 centimeters. This is important also, and porcelain gallbladder. Okay, where does gallbladder cancer spread to first?
First, spread to liver.
Okay, and what the next site? What is the most common next to the liver?
Accordingly, it may be to the stomach.
Yes. What else?
Yeah.
To the surroundings in general, the stomach, the lymph nodes, and the porta hepatis, maybe the bile ducts themselves. Okay. What's the most common pathological type of gallbladder cancer?
Adenocarcinoma.
Yes, the most common is adenocarcinoma. If the operative wound breaks down and there was yellowish and smelly discharge, what is your diagnosis?
Usually infection, maybe most probably bacterial infection.
Okay, so it's sepsis, most probably bacterial. What is the most common organism causing surgical site infection?
Staphylococcus aureus.
Yes. If you have minimal inflammation in the wound with, I'm sorry, there is a wrong, it's written wrong here, with no local cellulitis, what will you do?
With no local cellulitis, I'll open the wound and drain and clean the wound, and then take a swab for culture and sensitivity.
Yes, and I would leave the wound open for free drainage.
Yes.
Okay, great. So a few days later, okay, the patient condition deteriorates with high fever, tachycardia. The wound and the surrounding local tissues became very congested with purple discoloration and tissue necrosis. What is the most probable diagnosis now?
It will be necrotizing fasciitis.
Okay, thank you. What are the most common organisms causing necrotizing fasciitis?
So Staph aureus and Strep pyogenes and Vibrio vulnificus and Clostridium olshae.
Clostridium what?
Olshae perfringens.
Yes, okay, great. Yes, so we can say also it's a synergistic infection because it's mostly microbial. But right, yes.
Okay.
We can say synergistic infection caused by, and then we mention these. Okay. How can you suspect the diagnosis of necrotizing fasciitis? I mean, clinically.
Clinically?
Yes.
There would be redness and hotness around this. Also by there's some crepitus during palpation, feeling some crepitus.
Yes, so you are right, but we have to mention also there will be systemic manifestations. The patient may have fever, tachycardia, and then there will be local like pain. The patient will have severe pain, okay, disproportionate, okay, and then we have crepitus, cellulitis, purplish discoloration, and all of this. Okay, what are the pathological changes in necrotizing fasciitis?
It is extensive necrosis for the skin and the underlying structures with thrombosis of blood vessels.
Yes, right. How would you treat such a patient?
I will treat it by Firstly, I will treat the systemic cause for according to APC protocol as hemodynamics. Is a patient hypotensive, I will start with resuscitation, give him pain for analgesics for pain.
Okay,
Also,
great. So after resuscitating the patient, what?
CRESP protocol, I said.
Yes, yes. After doing the
protocol.
CRESP and resuscitating the patient,
Surgical
what does,
debridement.
yes, how you do it?
Surgical debridement for first
Yes.
opening the wound and clear any pus from this one and taking culture for it. Then by knife surgical incision to reach the clear margins.
Yes. So we will do yearly extensive surgical debridement, removing all dead and necrotic tissues until healthy and bleeding tissues are reached. Okay. And it could be repeated. Okay, we do a second lock. Okay, and you said antibiotics?
Yeah, and taking before giving antibiotics, taking culture.
Yes, and discussing with the microbiologist. Yes, great. Okay. And who would you involve in the care of this patient?
Involve anesthesia,
yes.
And also plastic surgeon or general surgeon, also ITU registrar.
Yes,
because the patient may be indicated to admit to ICU.
Yes, most probably, yes, it will be admitted to high care. Okay. A few days after receiving treatment, including broad-spectrum antibiotics, the patient developed bloody diarrhea. What's the differential diagnosis of post-operative bloody diarrhea?
As general, it is maybe inflammatory bowel disease, maybe acquired infection, and after using antibiotic, it may be pseudomembranous colitis and ischemic colitis as well.
Okay, great. Okay, so now colonoscopy was done to this patient, and this is a colonoscopy picture. What can you see?
I saw inflamed me or him.
I saw like volcano-like eruptions according to the brains of
okay, can you describe it? You just describe what you are seeing. You see yellowish, multiple yellowish flakes and the eruptions in front of you. Just describe what you see. Okay. And with inflamed mucosa in between. Okay. And this is called pseudomembranous
colitis.
Yes. So can you tell me what's the pathological process responsible for this picture?
It's usually associated with using broad spectrum, especially with hospital admission. Using antibiotic regularly lead to kill the normal bacterial flora. This gives a chance for Clostridium difficile colonization, and then causing disruption of bowel flora and forming.
How they cause? So you mean they cause disruption of the mucosa? Okay, and the flora. How?
By secretion of toxins, which is called toxin A and B, that's secreted by Clostridium.
Yes,
and
great.
Toxins causing inflammation and especially in large intestine and leading to vascular permeability increase and pseudomembrane formation.
Okay, so the toxins secreted by the Clostridium, they are directed to the mucosa, against the mucosa, okay? And they cause mucosa, cause mucosal damage, resulting in exudation of proteins and inflammatory cells, and this what forms the pseudomembrane. Okay, you said it right, by the way, perfectly يعني, بس I'm just explaining يعني. Okay, how you clinically suspect pseudomembranous colitis?
Clinical suspect because the patient has abdominal pain and diarrhea, severe diarrhea,
Yes, patient is hospitalized.
And
Okay.
hospitalized for a long time.
Yes, and taking antibiotics.
And taking, but it's clinically or just from history?
ما هو clinically دي including history يعني clinical
So
the history.
by the history of the patient will be admitted in the hospital for a long time and taking a broad spectrum antibiotic for a long time.
Yes.
Then he started to complain about diarrhea and
Yes.
abdominal pain for this patient.
Yes, and then developed fever.
74 years old.
Yes, so he's old, hospitalized. What you said is all right. I'm just recapping. Old, hospitalized, taking antibiotics, having diarrhea, corky abdominal pains, and fever. Great. How to confirm this diagnosis?
By colonoscopy and also first investigation CBC and full blood count. Then by this laboratory investigation. Also then for imaging, I will do
laboratory investigations like what? What you're looking for?
Full blood count and the stool biopsy.
التوكسين بتشخصها بايه؟
Yes.
By what?
Toxins by ESR ELISA.
ELISA. Enzyme linked immunoassay for toxins. And yes, and you can also do PCR.
Okay.
Okay. So, and you said colonoscopy. Okay.
This will be. We should classify it as Dr. Salah said.
Yes, of
laboratory
course.
And
we said imaging and laboratory, and the imaging non-invasive like X-ray. Okay, there may be toxic megacolon in severe cases, and more invasive. Okay, like CT, but I think it's here. It's abdominal X-ray. You can say maybe CT, but colonoscopy is important also. Okay.
Okay.
So the laboratory test again, we do full blood count, we do PCR for the toxin, and we can do also enzyme-linked immunoassay or ELISA for the toxins, and also immunoassay for the enzyme glutamate dehydrogenase. Okay.
Okay. Okay.
Okay. Okay. How can you treat this condition?
It is depends on the case, as it may be moderate or severe. With acute management, first I'll stabilize the patient, then I'll start the antibiotic according to the hospital protocol. Usually I use the first line, I use vancomycin for 10 days if it is mild or moderate case. Then if it is fulminant, if severe, I will use vancomycin with IV metronidazole. And
you use vancomycin oral or IV or what?
No, as per the acute cases, I use oral, not IV, as it is.
Yes. So you always say the drug, say the route, and if you can say the dose and the duration, it's very important.
Okay, it's the duration for 10 days. Oral vancomycin. This is the first line usually with supportive case and using infection control measures. Then the second line, I go for intravenous metronidazole with vancomycin.
Yes, 500 milligrams. Yes.
No, this not the second line. This not the second line.
No. انا هقولها بعد ما نخلص اصلا، بس يعني انا اشوف ايه، لان هم في ريسنت جايد لاينز مقسمينها مايلد ومودريت وسيفير وريكارنت.
دي اللي قايلها لهم، دي اللي انا قايلها لهم.
طيب دكتور صلاح، احنا ممكن يعني انت في المايلد احنا بنجيب مترونيدازول،
ده غيرناه.
ما انت انا عارف، ما انت قلت فانكومايسين في المايلد، بس هم اصلا في المايلد. نعم.
اورال في المايلد في الفانكومايسين مع او
مترونيدازول كله اورال. مايلد مودريت سيفير كله اورال. استنى بس،
كله اورال. فانكومايسين از نوت افكتيف غير اورال في دي في السودو ميمبرينز. المترونيدازول اورال في المايلد او بس في السيفير بندي اي في.
بدي فلاجيل اي في. ماشي.
يس but vancomycin always oral.
طيب تمام. بص طيب
وفي
بقى اسئله الاول، بقى اسئله عشان نخلص بس ديت، بقى اسئله.
اوكي نقولها في الاخر.
ماشي
اوكي.
ماشي.
And stop the cause by the way, yes.
اوكي
Of course, stop the antibiotic, the causative agent. اوكي
كده خلاص.
هو ده كان last question.
طب ارجع اول هبقى اول اللجنه يلا. اوكي اولها كده. اوكي wait. First question, if the wound, number 5, I wanted to comment it from here. If the wound breaks down with yellowish and smelly discharge, what's your diagnosis? We told the local sepsis. So next question, what is the most common organism? You will tell auris. Staph. It's written for the examiner. I am coming to answer your question. Okay. If ask, it's written to the examiner. Does not have to be specific, but only one answer permitted. Yani, so if you will tell what is the most common organism in the surgical site infection, it's written in the checklist. Name the single most likely organism causing this change. So staph. What you will do, like question number 7, if you have minimal inflammation with local cellulitis, it's written. If you have no, it's written by this way, Murad. If there is no local cellulitis, if you have no local cellulitis, and you have inflammation only around the wound, management, four things. Open the wound, take bacteriological samples, clean the wound, allow drainage. Open the wound, clean the wound, allow drainage, and take sample.
Yes.
Then the question of ascites, as you discussed.
He said it right. يعني هو الفكره ان في انه قايل no local cellulitis, you don't have to mention antibiotics. يعني هي دي الفكره from no local cellulitis يعني. طيب next we have
name 3 bacteria you discussed it already. You should tell polymicrobial and the bacterial group A is streptococci, staphylococcus aureus, clostridium perfringens, and vibrio, and also bacteroid. Then how to manage this necrotizing fasciitis, surgical development of all dead and infected tissue down till the viable areas of the tissue.
Yes.
Number 2, antibiotics.
طيب.
Microbiologist.
Okay.
Then about diarrhea organisms or the cause of blood diarrhea, Clostridium difficile, ischemic colitis, hospital acquired infective enteritis, and inflammatory bowel disease de novo presentation. By the way, I remember this question. I told before, examiner told me this 4 marks, by the way, this question by 4 marks, by the way. The examiner told, and the organism is 3 marks. The organism is 3 marks. Okay, so examiner told me you answer the 3 only correctly. They want this 4: Clostridium difficile colitis, ischemic colitis, hospital acquired, and inflammatory bowel disease.
Okay. So دكتور صلاح to recap بقى عايزين نقول treatment of the CDI infection Clostridium difficile.
ماشي، انا هقولهم انا دلوقتي. ماشي.
لانها على فكره confused، وانا قريت الريسنت UK guidelines يعني complicated شويه. And it's also important how to know severe infection. He may ask you, if he told the examiner in severe cases, he may ask you what do you mean by severe infection?
Yes. Okay. You have non-severe cases and you have severe cases. Now severe and non-severe. Non-severe, according to leukocytic count less than 15,000, creatinine less than 1.5. The first line, vancomycin 125 milligram QID, 125 milligram QID for 10 days.
10 days.
Orally. Second line is Videxa.
Fidaxomicin, yeah.
If this not available, you can go for metronidazole.
ده في mild or severe?
This non-severe cases.
Non-severe, yes. And in severe
cases, it is the same. It is the same also. Severe cases, leukocytic count more than 15,000 and creatinine more than 1.5. First line also vancomycin, and the second line also can be Videxa. It is the same.
يا باشا هو الوايت بلاد سيلز حضرتك قلت كام؟ بقسم على اساسها
15 less than ده mild more than moderate، وفي حاجات تانية للسيفيريتي برضه يعني، بس ايه خليكم في الليكوسايت.
Now we are coming for fulminating, hypotension, shock, ileus, megacolon, or complicated, here you will give also
Connecting
mycin oral, but not 125. It will be 500.
500.
And you will add IV metronidazole.
And we may need to do surgery. يعني in severe
So to do
cases.
more medication,
Yes.
go for surgery.
Yes. Okay.
جايد لاين. خسر جايد لاين.
حضرتك قلت معلش يا باشا، حضرتك قلت
موجودة
الفانكوميسين في
على الجروب يا ابني، موجودة على الجروب والله، موجودة على الجروب.
موجود على
ماشي.
الجروب. اوكي. دكتور صلاح
احنا ماشيين ببطء رهيب.
معلش.
بس الدسكشن ممتاز على فكرة.
طيب احنا انت كده خلاص كلير. طيب طيب next station we have.
ادينا بريك لان كده اللجنه دي كانت تقيله. 10 minutes then we'll be back at 9. 10 minutes.
طيب خلاص ماشي يا باشا. اتفضل. Okay, so we have a patient with a known peptic ulcer disease presented with hematemesis, OGD done, showed bleed in gastric ulcer, labs showed hypercalcemia. Can you please tell me what's the definition of an ulcer?
It's also is a breach of the continuity of the mucous membrane, skin, or epithelial surfaces due to sloughing of the inflamed necrotic tissue.
Yes. Okay, so what are the major risk factors of peptic ulcers?
H. pylori.
Sorry, H. pylori and what else?
H. pylori, non-steroidal and smoking.
Yes. Can you tell me how can non-steroidals cause peptic ulcer?
Local irritation by non-steroidal interfere with mucosal protective barrier of the stomach.
Yes.
Inhibition of the protective prostaglandin.
Yes.
Reduction of
how they suppress prostaglandins?
COX inhibitor.
Yes, cyclooxygenase inhibitors. Yes, great. What else?
Okay, and reduction of blood supply, so interfere with reparative power of small defect or injury.
Yes, great. Can you tell me what's H. pylori?
It's a gram-negative spiral bacteria. It's also microphilic.
Found where?
It's the antrum of the stomach.
Yes. After taking a gastric biopsy during endoscopy, what test can be done to the biopsy to confirm H. pylori infection?
Campylobacter-like organism test.
Yes.
So
can you describe it? Yes, describe how it's done.
Okay, during endoscopy or gastroscopy, we take biopsy from the gastric mucosa. If it's contain urease, which is enzyme produced by H. pylori, we put it on a medium rich in urea. So if this enzyme exists, we'll convert the urea to ammonia, and also the medium contain indicator like phenol red. So when ammonia produce increased pH and the converted the phenol red from yellow to red give positive test.
Yes, great. Perfect. Okay. How does H. pylori manage to survive in the gastric acidic medium?
By producing urease that hydrolyzes urea to ammonia, it elevates the local environment pH level, so it survives the acidic levels of the gastrum.
Yes, right. Great. How can H. pylori colonize the stomach and induce gastritis?
Okay, it's flagellated organism, so can move in viscous medium. This is first. Second, by production of adhesine, which permit adhesion of the organism to gastric mucosa. Third, by production of urease, which convert to urea to ammonia, so elevate pH and neutralize the acidic medium around it.
Yes.
And finally, the toxin produced by H. pylori can produce ulcer or malignancy with unknown mechanism.
Yes, like the cytotoxin associated gene A. Okay, great. Can you tell me what are the types of gastric antral mucosal epithelium? Sorry, the type of gastric antral mucosal epithelium
Is adenocarcinoma.
No, I'm asking about the normal.
Oh, sorry. Yes, it's
Yes,
it's
antral
a
mucosal epithelium. What is the
yes,
type of the epithelium?
it's a columnar epithelium with mucus and goblet cells.
Yes, perfect. What are the types of gastric cancer caused by H. pylori infection? And which immune?
Adenocarcinoma
Yes. What else?
and mucosal associated lymphoid tissue tumor.
Yes, or maltoma. Which immune endocrine disease is associated with that?
Hashimoto's thyroiditis.
Perfect. Okay. How to treat symptomatic H. pylori infection?
By a full course for 7 days of triple therapy consists of PP proton pump inhibitor and clarithromycin plus metronidazole or amoxicillin twice per day.
So metronidazole plus clarithromycin or amoxicillin plus clarithromycin. Do you mean this?
We have two options.
Yes,
First
yes.
option,
So yes, you understand. Okay.
Okay.
Perfect. Great. So next question. Can you tell me what are the actions of gastric HCl? I'm sorry. The actions of proton pump inhibitors.
Yeah, it's binds irreversibly to hydrogen potassium pump on the gastric parietal cells, which inhibits the secretion of the hydrogen ion, which will combine with the colloid in the lumen of the stomach that forms HCl.
Yes, great. And now, can you tell me what the actions of the HCl itself?
Activation of pepsinogen to pepsin and provide optimum acidic medium for action of pepsin enzyme.
Yes.
Antimicrobial function with this acidity, help absorption some element like calcium and ferrous ion. This acid medium, when reach small intestine, promotes secretion of cholecystokinin and secretin, which regulate gastric secretion. And finally, acid chyme in intestine can promote secretion of pancreatic enzymes.
Great, perfect answer. Thank you. Okay, what are the other possible causes of hematemesis in these patients?
Hypercalcemia, which induces production of gastrin and induces production of HCl.
Okay, great. What are the common causes of hypercalcemia in general?
Hyperparathyroidism, malignancy, renal failure.
Yes, great. The patient had a history of recurrent renal stones. What is the possible cause in this case?
Hypercalcemia.
Yes. What's the commonest cause of primary hyperparathyroidism?
Parathyroid gland adenoma.
Yes, solitary adenoma. The most common is solitary because it may be multiple, but the most common 80% is a solitary adenoma. Okay, What is the meaning of adenoma in general?
It's benign tumor arise from glandular structure of epithelial cells.
Yes, benign epithelial tumor may form a glandular pattern. Okay, yes, that's right. Great. How can the parathyroid glands be localized?
Through preoperatively by systemically scan and intraoperatively frozen section.
Yes, great. Where can they be found if not in their normal location?
Superior mediastinum.
And why is that?
Because they originate from the pharyngeal pouch.
Which one?
The third one.
Yes, great. So they may be accompanied with the thymus.
Yes.
Okay, great. You said that intraoperatively we can use frozen section. Okay, can you tell me how we can do frozen section?
Yes. Simply frozen section is snap freezing, do sliding, staining, and microscopic assessment.
Okay, so snap freezing, cutting, fixation. Yes.
Fixation and
yes,
stain,
great.
microscopic assessment.
Yes, great. Why paraffin-based histopathology is not convenient for intraoperative pathological testing?
Because it takes about a week for the paraffin to be embedded in the specimen.
Great. How we can treat a parathyroid adenoma?
Resection.
Yes, excision. Okay. So the patient underwent excision of the parathyroid glands, and you have a pathology report which shows that one gland measures 0.2 gram chief cells and the other 3 glands ranging from 0.08 to 0.09 with oxyphilic cells and fat cells. How can you interpret this pathology?
It's parathyroid adenoma, and also it's involution of the other glands.
Yes, so the adenoma, so it caused the involution of the other glands. Okay, so what are the histological features of parathyroid adenoma?
It affects mainly sheath cells, become a sheath of cell with fibrous strand and may island of oxyphil.
Yes, so it's mostly composed of chief cells, and there is some nestus of oxyphil cells, but there is some types that composed entirely of oxyphil cells, and there is a capsule, fibrous capsule, okay, surrounding the normal compressed tissue. Okay, great. And how does it compare to hyperplasia, parathyroid hyperplasia?
Hyperplasia is non-malignant condition characterized by increased number of cells to certain stimulus.
Okay, and what would you find in the pathology report of hyperplasia? And what is the histology of hyperplasia itself?
It will be the same sheath cell mostly, sometimes maybe clear cell, hyperplasia.
Yes, water clear cells. Yes.
Water clear cell.
Yes, great. What are the types of hyperparathyroidism?
Primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism.
Yes, can you please tell me the cause of each one? Primary,
Yes,
in primary hyperparathyroidism, what is the most common?
Most common is solitary adenoma, about 80%.
Yes.
Secondary hyperparathyroidism is usually due to chronic kidney disease or vitamin D deficiency. And tertiary hyperparathyroidism usually happens after correction of renal failure or renal transplant.
Yes, yes, great. How to treat hypercalcemia? I mean acutely, and if the patient has acute hypercalcemia now, how to treat it? Yes.
Hydration, enforced diuresis, bisphosphonate, and calcitonin.
Okay, great, great. This was the end of our station, and I would like to thank you both. You did very, very well.
Thank you.
Thank you. Dr. Salah.
For both of them.
Huh?
I have one question for both of them. Dr. Aya, when asked you ارجع للستيم تاني، عايزة ترجع للستيم تاني بعد إذنك.
Okay. Okay. ثانية واحدة.
The real stem should be added two things. Why? The question asked about the risk factors. He's asking about the major risk factors for peptic ulcer in this patient. So in the stem, this patient is taking a non-steroidal anti-inflammatory, and
yes,
he has positive infection of Helicobacter pylori. So this will be written in the stem. So please, when examiner asking you the question and the stem by this way, what is the major risk for peptic ulcer? Ask him. You are asking generally or specific for this patient?
Okay.
Because you should answer the risk factors for peptic ulcer disease from the scenario itself. So if you will look for the next questions, they are asking about non-steroidal anti-inflammatory and asking also about H. pylori. For sure, in the stem, they have infection by H. pylori and they have also taken non-steroidal. What is the mechanism of non-steroidal again, Dr. Aya?
Non-steroidal local irritation. Second is
mechanism of action.
Cyclooxygenase inhibitor, so inhibit synthesis of protective prostaglandin, interfere with protective mucosal barrier of the stomach, reduction of blood supply, so interfere with the reparative ability of minor injury.
Ask by another way, non-steroidal anti-inflammatory. Which enzyme will inhibit synthesis of prostaglandin? Will inhibit prostaglandin by which enzyme will be inhibited by non-steroidal?
COX.
COX.
Yes, cyclooxygenase. Yes.
I said COX what?
يعني always say the full name.
No.
Yes, 1 and 2, both of them.
This is asked in Cairo this time. COX, which COX? You have how many COX?
We have
Yes.
2, 1 and 2.
Oh,
Which
so which
one?
one or two?
Non-steroidal inhibit both of them. It is non-selective.
Yes. Which one will cause peptic ulcer? I'm asking which enzyme.
Yeah, understand it. COX 1.
Yes.
Or COX 2?
No, COX 2, it's another problem related to kidney, I think.
Okay. So what are COX 1 and COX 2? Two COX enzymes are known to be involved in prostaglandin synthesis, COX 1 and COX 2. COX 1 generates prostaglandins that are involved in protection of gastrointestinal mucosa. So COX 1 will generate prostaglandins which will be involved in protection of gastrointestinal. By the way, this came in critical care station last exam. Another question. Dr. Sarah, you answered again. What is the mechanism of action of proton pump inhibitors? Repeat it again.
Yeah.
Why muted yourself?
زهقت.
Mechanism of action again.
Sorry, it binds to the hydrogen potassium ATPase pump on the gastric parietal cells, and also blocks the secretion of the hydrogen ion, which with the chloride in the lumen forms HCl.
Just tell again, repeat your answer. Again, repeat it again.
Okay, so the protein pump inhibitors, it binds irreversibly to the hydrogen potassium ATPase pump.
Enough. He's waiting irreversible blocking. He's waiting this irreversible blocking. By the way, this came in critical care station in Cairo last exam. So I want to confirm about them from Yalla, next station. Excellent.
Okay, so next station we have Broma and Muhammad Fadel. Broma, okay, and Muhammad Fadel. Okay, I can't find Muhammad Fadel. He's not raising your hand. Muhammad Fadel, if you are here, please raise your hand. Okay, ما فيش. So we have Adnan. Raise your hand, please. Okay, ما فيش عدنان. So تنظيم أو إسراء صالح. Okay, so I think they are running now. يعني مش عارف. Okay. So okay, we have one Mansour. Okay, ماشي. Okay, so we have Broma and Mansour. Are you ready?
Yes.
Assalamu alaikum.
Wa alaikum salam wa rahmatullah. Okay, so we will start our station now. A 60-year-old lady who is chronic alcoholic, and she was diagnosed with gastric cancer. She underwent gastrectomy and splenectomy due to iatrogenic. Please, someone has a noisy background. The patient has also osteoarthritis. So you have the following pathology report in front of you. It's signet ring cell carcinoma with positive lymph nodes and positive margin, and the spleen was involved. Okay. Sorry. So Can you discuss this pathology report with the patient's family in 4 simple sentences?
Okay, I'll tell that this is the cancer of a stomach, and there is incomplete resection, so there is high possibility of recurrence, and the patient will require further resection and chemotherapy.
Yes, you said right, but you have to simplify it more in layman terms because you are talking to the family. So this cancer of the stomach, yes, right. It has not completely removed. This is incomplete resection, and there is a high chance that the tumor will come back again, and we will need to do a further surgery and may give the patient chemotherapy. Okay.
Okay.
Great. So what's the plan for the patient post splenectomy?
The patient need to be vaccinated for at least for 2 weeks after the operation.
Okay, which kind of vaccines would you give this patient?
Vaccine for polysaccharide capsulated organism like Neisseria meningitidis or Haemophilus influenza or strep pneumoniae.
Yes, and what else would you give the patient? You give the patient vaccination. You need to protect
antibiotic.
Yes, we give prophylactic antibiotics. To protect the patient against OPSI, overwhelming post-splenectomy infections. Okay. Can you please mention 4 important risk factors for gastric cancer?
There is Helicobacter pylori infection, chronic atrophic gastritis, intestinal metaplasia, pernicious anemia, adenomatous polyp.
Yes, right. Yes, this is very important. And you can say anything else, but the first 4, these are actually the most important.
Also FAB and
yes, and HNB, yes, also
HNPCC.
and previous gastrectomy, but these are the most important. Okay, how does gastric cancer develop? What are the pathological steps?
Start by gastric chronic irritation, and after that it's going to hyperplasia, dysplasia, carcinoma in situ, then after that diffuse cancer.
Yes, this is in general, but there is more specific terms in cases of, there is chronic gastritis, it causes intestinal metaplasia, okay? Then, as you said, dysplasia, intramuscular carcinoma, and then invasive gastric carcinoma. But what you said generally is right. Okay, so what is the commonest histological type of gastric cancer?
Adenocarcinoma.
Okay, do you know any other gastric cancers?
Yes, there is gastrointestinal stromal tumor.
Yes.
Hereditary diffuse gastric carcinoma.
Yes.
And, sarcoma.
Yes, leiomyosarcoma. This is right, and also neuroendocrine tumors like carcinoid.
Okay.
We said lymphoma, I think, also. Okay.
Yes, lymphoma.
Yes. Great. You said diffuse gastric carcinoma. I will ask about this in the end, okay? But you said it perfect.
Yes.
Okay, so do you know any classifications for gastric cancer?
First classification, it's classified to tubular gastric cancer, also papillary.
I'm sorry to interrupt. Please mention the name of the classification.
This is WHO classification.
Yes, يعني it's important you say we have WHO classification and the others like whatever and then mention.
Loren and Broman classification.
Yes, perfect. You say them and then try to start to elaborate them.
Okay.
Okay, so
for WHO classification, there is tubular, Also, there is papillary gastric cancer. There is cohesive, and there is
poorly cohesive.
Poorly cohesive. Yes, poorly cohesive, and there is the mucinous, and the last one is mixed.
Yes, great. And for Lauren classification?
For Lauren, it's classified to two types: intestinal, which is good prognosis, and diffuse, which bad prognosis.
That's great. And finally, we have the Bowman classification, which is the microscopic appearance.
Yes, it's fungating, polypoid, and diffuse and ulcerating.
Yes, diffuse, infiltrating, and ulcerating. Okay, great. 10 days after resection, the patient developed diffuse painful swelling of the left arm. What do you think has happened?
Thromboembolism of the axillary thromboembolism.
You mean thrombosis?
Yes.
Of the axillary vein, not embolism. Okay.
Yes.
So, what are the predisposing factors in this patient for this condition?
Patient is malignant, so hypercoagulable state, and there can be venous stasis due to varicose lymph node.
Yes, great. So, next question. How can you define paraneoplastic syndrome?
Paraneoplastic syndrome is a group of symptoms and signs that not related or anatomically described by the origin of the cancer.
So you said that the group of symptoms that occur in patients with malignant neoplasm that cannot be explained by either the tumor itself or by the distant metastasis of the tumor.
Yes.
Yes, great. So in gastric cancer, okay, what are the paraneoplastic syndromes that can be found in a patient with gastric cancer?
Dermatomyositis and acanthosis nigricans.
Yes, great. Perfect. Thank you. How does gastric cancer spread first?
Gastric lymph nodes first.
Yes. So it's a carcinoma, so it spreads first by lymphatics. Okay. After following the local invasion, but the distant spread occurs first by lymphatics. You are right. Okay. What are the...
Sorry, what is lymphatic? Which lymph node?
There is
gastric
Irish
lymph nodes.
What?
Yes.
You told lymphatic. Which first lymph node will be? Which first lymph node will be?
First, locally first gastric lymph node, and then distantly it can be supraclavicular lymph node.
Yes.
Wait.
دكتور صلاح.
يا شباب اسمعوا يا اخوانا ما تصبروا بس واحده هو في ايه؟ I'm coming for the question which is I are stuck in. فنسمع بس كده. You told gastric lymph node.
Yes.
Which gastric? Left gastric.
I don't know. Okay. Left gastric.
بص يا مراد هو كان انا ما قلتوش في الاناتومي. He was sitting for this answer about the spread of some cancer, and the answer told gastric lymph node, then celiac. Which gastric? He's waiting. Which gastric one? So left gastric.
Okay.
معلش لازم اوقفكم فيها.
Okay. يبدأ بالليفت gastric along the lesser curvature بعد كده بيروح للسيلياك. Okay. So can you please tell me what are the other routes of spread?
There is for me or for Dr. Proma?
You can answer. She said lymphatic, so what next?
There is transcelomic.
Yes.
And by blood.
Yes, which occurs late.
Yes.
Okay. So 6 months later, the patient presented with abdominal distension with positive shifting. What's your diagnosis now?
Ascites.
Okay. Can you mention two pathological tests to confirm the
I'll
nature
do
of ascites? Yes.
first, I'll do ascites step and send for cytology. And I can do a liver biopsy for metastasis. Also FNSC for supraclavicular lymph node and tumor
Yes.
marker.
Which tumor markers?
CS72-4.
Okay. What else? You can do also alpha fetoprotein, carcinoembryonic
Yes.
antigen. Yes. Okay. And of course, you have to mention FNAC for Virchow lymph node. If it's
Yes.
mentioned in the stem, it's very important. Read the stem well. Okay. What would be your plan if this is a recurrence and an advanced disease? So the patient have a recurrent gastric cancer with ascites. What's the plan for treating this patient?
Mainly palliative treatment. I
Yes.
can go for feeding jejunostomy for nutritions, then palliation of the ascites by repeated tapping, pain relief by opioids, then palliative chemotherapy.
Yes. Okay. And there are many treatments for malignant ascites. I think Dr. Salah, we will mention them at the end in the update.
Yes.
Okay.
Yes.
Okay.
There is peritoneovenous shunting.
Yes.
Or, infusion of
Yes.
the ascitic fluid
Yes,
concentrated.
it's complicated name. It's cell-free
Yes.
and concentrated
Cell-free
ascites
and
reinfusion therapy.
concentrated ascitic fluid reinfusion therapy.
Yes, great. Okay, how does ascites develop in this case?
Hypoalbuminemia and increase in oncotic pressure.
Hypoalbuminemia and what?
Decrease in oncotic pressure.
They are, by the way, they are the same.
And
Again,
decrease also.
yes, you have increased hydrostatic pressure and decreased. Okay, I just want to clear this point. You have increased hydrostatic pressure and decreased plasma oncotic pressure because of hypoalbuminemia. Okay?
Okay.
Okay. These, by the way, are called stalling forces. They are the cause of any edema in the body. And in this case, it occurs because of liver metastasis, mainly. Yeah. Okay. So what are the procedure-specific complications of total gastrectomy?
There are some early complications and late complications. Early,
Yes.
maybe infection, hemorrhage, anastomotic leak, development of cholecystitis or pancreatitis. And late complications can be dumping syndrome, vitamin B12 deficiency, anemia, metabolic bone disease, and
Okay.
malignancy can recur.
Okay. Okay. So great. Can you tell me what's dumping syndrome?
Me or Dr. Roma?
Yeah, you can answer. You can.
It's dumping syndrome is loss of stomach reservoir. So there is a large number of the gastric fluid going to the small intestine. So there is two dumping, early dumping and late dumping. For early dumping, there is a large amount of hyperosmolar.
When early dumping, when does it occur?
It's
Early. What do you mean by early?
Early about half hour to 1 hour after eating.
Yes.
And late about 3 hours after eating.
And what is the difference between the two?
For the early, there is a large amount of hyperosmolar fluid going to the small intestine. So there is shifting of fluid from the vascular to interstitial space. So this is cause hypotension.
You mean from the intravascular space to the gastric lumen itself?
Yes, yes.
Yes.
So this is cause the hypotension and headache and weakness for this is for early dumping. For the late dumping,
these are the hypotension and the tachycardia. These are the vasomotor symptoms. There is also intestinal symptoms like distension, colchi abdominal pains, diarrhea. Okay.
Yes.
So For late dumping,
For leg dumping, there is large amount of carbohydrate also going to the from the stomach to the small intestine, and that making the high shot of the insulin in the blood. So it's going to the hypoglycemia.
yes, hyperinsulinemia cause rebound hypoglycemia. Great. So this is the station finished, but we have a lot of updates, I think, Dr. Salah, about diffuse gastric cancer. And
I discussed with them yesterday about these questions, but I will do it again.
أحسن يعني I have a lot of questions myself, but يعني we can discuss it together. Yeah.
Okay.
She said that the patient. Okay, you have them organized. Perfect.
First, this was the station when came in UK in February. I'm sharing. I'm sure this. Okay. This like came in UK February. Since this station was repeated in Cairo exam and repeated also in Bahrain.
They seem to like it, yeah.
They started to repeat it again by another way. First is a histopathology report. When asked you, given the pathology report, question number 3, they have in it about 14 to 19, 14 from 19 lymph node positive, and what you will tell the family, poor prognostic factor, like this way. Okay. The first question in this station, as I told you yesterday, the STEM states that the patient has gastric carcinoma, splenectomy, and elevated liver enzymes. I'm starting from the beginning when this station came. Jacobs, he told me that the gastric carcinoma 1, they told us the gene related to gastric carcinoma, and asking us the type of the mutation, the question was very unclear. This is the first time. Then Amr Mohsen told me about this station. They asked about the gene and other cancer related to liver carcinoma of the breast and
prostate. Yeah.
Okay.
Breast and prostate.
Then he told me the STEM states that the patient had gastric carcinoma, elevated liver enzymes. So it started with the risks that cause the cancer in the stem. The risks causing, so the patient is alcoholic and smoking. It will be written in the stem. I started by this way. Then the question asked about the liver, why enzymes are elevated. Liver enzymes were elevated. So why liver enzymes are elevated? Because of what?
Invasion, direct invasion to the liver.
Okay, what else? Compression and direct invasion of the liver. What else? Meds to the liver.
Meds to the liver, yes.
And by the way, alcohol also.
Alcohol.
Yes,
okay.
The patient is alcoholic.
In asking what could be the cause of confusion for this patient?
Hepatic encephalopathy.
Hepatic encephalopathy.
Or patient may be, he has ectopic disturbance in form of hyponatremia. You should confirm about this. Okay, other question from the book. Okay, then I get the forestation from Bahrain and Dubai. They told me the STEM states that the patient has gastric carcinoma, splenectomy, and elevated liver enzymes. What are the risks to cause this from the STEM, alcohol and smoking? If you have mutation in your CDH1 gene, what types of cancer may be associated? First, he asked first, what is the which gene you will do screening for it or something like that. So CDH1 gene, what other cancer? We discussed the diffuse gastric cancer and lobular breast cancer, prostatic cancer, colon cancer. Causes of malignant ascites and the management of ascites. Causes of malignant ascites and the management of malignant ascites. Management, as we discussed yesterday, simple drainage, peritoneum venous shunting, like we discussed before, and the treatment of the underlying cause by chemotherapy or by surgery. Okay, management in details in the picture. I shared it. Why liver enzymes are high discussed. Why confusion discussed. Other questions from the book. Ask it again about CDH1. CDH1, whom will be screened? Whom will be screened? Some told يعني one in Bahrain, he told me only one small answer. He told me if this patient has a lobar carcinoma of the breast with cancer, gastric cancer. Examiner was very happy, by the way. He was very happy. But you should answer it if you want in details. Like I told, if you have 2 or more cases,
documented cases
of gastric carcinoma, one of them first or second degree at any age. One of them confirmed diffuse gastric carcinoma at any age. Or I have patient has diffuse gastric carcinoma before age of 40.
40.
And the families with diagnosis of both diffuse gastric carcinoma and lobar carcinoma, at least one of them before 50. Then I from Cairo, 4th day of December. Some told me, I think, okay. Rest is the same, only find examiner didn't accept 2 answers in gastric cancer. It was about reason of jaundice and increased liver enzymes. I think like we discussed now. The CDH1 who will be screened, we discussed it. What others cancer of gastric carcinoma? You can tell guest lymphoma, sarcoma, maltoma, and like this way. I think all the questions discussed from this station before, and we repeated them again.
Okay.
In Cairo, by the way, في امتحان القاهرة في شهر 12 in month in December, people who has the repeated exam, when this station came for them, they told all the questions as we discussed are accepted. So don't worry, this all the updates will be accepted إن شاء الله. اللي بعدها.
Okay. Okay, so next we have Nabila Ahmed and Farheen. Okay. Everyone was shouting at me because they wanted to participate, and now I can't find anyone. So please raise your hand, Nabila and Farheen. Okay, so Nabila here. Okay, great. And where is Farheen? Okay, so I will choose another one, maybe Isra. Okay, great.
Hello.
Hello.
How are you, Dr. Murad?
I'm fine. How are you doing?
Thank you.
Great.
بقينا 5 لجان وفي 3 ساعات. دوس واجري. هم عاجبهم طريقتك. انا شفتهم كاتبين هم عاجبهم طريقتك. لكن انت
بس انا مش عاجبني. I don't like it.
مش هندخل 4 ساعات. انت
يلا. Okay. Now we want to run.
We'll run.
Okay. 60-year-old male with rectal bleeding, rectal examination revealed external hemorrhoids. Colonoscopy was done with biopsy, revealed adenocarcinoma with melanosis coli. Histological examination of the specimen revealed a lesion invading up to the muscularis propria. Patient has a history of coronary heart disease. How can you stage colorectal cancer? And what's the stage of this tumor?
The colorectal cancer can be staged by Duke staging and TNM staging.
Okay. So what's the stage of this tumor? You can say it with Duke's staging. It's invading to the muscularis propria, and there is no positive lymph nodes.
So it's a B2, Duke's B2.
Yes, this according to Duke's. Okay, and you need also to know TNM because it's more important and most commonly used.
Okay, it might be T2, MO, MX, and NX. N0, M0, sorry.
Yes, because we don't know. Okay.
Yes.
We don't know actually. It's not
Yes.
written here.
Written there. Yes.
What are hemorrhoids and
Yes.
how does they occur?
Yes, hemorrhoid, it's swollen or inflamed anal cushions.
Okay, how does they develop?
They developed when the anal cushions function normally when they return to its proper sites within ligaments, which is fibromuscular ligaments. But when there is high pressure or more straining during, for example, during defecation, these anal cushions no longer return to its site, and may this cause
You mean they become stretched by straining?
yes, stretch.
Yes. Okay.
Yes. So this may cause bleeding or
yes, or swelling, as you said.
Yes, swelling.
Yes. So what's the pathogenesis of a thrombosed piles?
In acute thrombosis, where there is raised pressure, sudden raised pressure causes rupture of the venous plexus of the anal cushion, which causes blood clot in the anal wall.
Actually, don't say the anal cushion because it's a different pathology.
Okay.
It's a vascular plexus, okay? Rupture of the vascular plexus causing a blood clot at the anal verge, because the anal cushion, this is the internal bile, and this one would be external.
External.
Okay? Yes. Occurs with any condition causing excessive abdominal straining also. So can you please define melanosis coli and what's its significance?
Yes, this is a benign condition that it's pigmentation of the wall of the colon can be seen on colonoscopy.
Yes, it's accidental finding during colonoscopy, non-significant. Yes. It's actually due to deposition of lipofuscin dye, and it's related to chronic use of laxatives. So why does coronary artery get thrombosis? The patient has coronary heart disease. So can you tell me how did they get thrombosed?
Due to atherosclerosis?
Yes. Okay, great. So how does atherosclerosis itself occur?
Yes, atherosclerosis, first of all, when there is endothelial injury, this will result in accumulation of endothelial dysfunction and lipoprotein accumulation, then platelet adhesion. After that, the monocyte adhesion and lipid accumulation, then smooth muscle recruitment and smooth muscle proliferation.
Yes, a smooth muscle will proliferate and there will be deposition of extracellular matrix. Okay, to form the plaque. And just remember that monocytes will be transformed into macrophages and foam cells, because these are important. Okay. So now, can you tell me what are the risk factors for atherosclerosis?
There are some modifiable factors, some non-modifiable factors.
Okay.
The modifiable factors is hyperlipidemia, hypertension, smoking, diabetes. And from non-modifiable factors, there is genetic abnormality, positive family history, increasing age, male gender.
Yes, great. So can you tell me what, sorry?
No, sorry.
What are the common sites of atherosclerosis and what are their effects?
The common site of atherosclerosis, it can be a common site in large and medium.
Okay, so give me examples.
Can occur in lower limb vascular.
Yes, and they
in
will
the
be
brain.
causing what? Yes, you are right. And tell me the effect in the brain, what they cause?
The brain?
Yes.
Yes.
Cerebral vascular disease, like
yes.
stroke, like
Yes.
TIAs. In the lower limb, claudications, ischemia, like this. And what else? What are the other sites?
Lower limb,
Yes.
and can be in the heart, can cause myocardial infarction.
Yes, great.
Yes.
Intestine,
Yes.
it can cause
Yeah.
mesenteric occlusion.
Yes, mesenteric
Yes,
ischemia.
yes, yes, perfect. You know, so the coronaries, cerebral, renals, intestinal, mesenteric, I mean lower limb and the aorta. Okay, so next question. Not sure I can see it. Okay. Okay. Can you define a thrombus?
Okay, thrombus is a solid material that is formed by the constituents of blood in a static blood. In a static blood, yes.
Thrombus. Thrombus is formed in static blood.
No, yes. Am I wrong?
So what about clot?
Okay, I made a mistake. So thrombus is formed in a flowing blood, and clot is formed in a static blood. Sorry.
Yes. So can you please tell me what are the other differences between the thrombus and the clot?
Okay, thrombus has some white and red layers, but the clot has red caruncular appearance. And
Yes.
thrombus takes the shape of a blood vessel because it is attached with the blood vessel, but clot doesn't take any shape because it is not attached.
Okay, great. So next question. What is the mechanism of thrombus formation? Can you first tell me what is meant by thrombosis itself?
Thrombosis, it's
What?
a solid
Yes.
material that's formed from the blood constitution.
And what's the function of a thrombus?
It's prevent bleeding.
Yes, great. It's a simple question. Sometimes you ask a very simple question. So be prepared to answer simple questions.
Yes.
Okay, so how does it form a thrombus? Can you tell me the steps of formation of a thrombus?
Yes.
Okay, go on.
Actually, I can't recall this question.
Okay, so either of you can answer.
Yes.
Okay,
yes.
should
okay.
I?
Yes.
Okay, thank you. So when a thermometer plaque is formed, then is suddenly disturbed by an intraplaque hemorrhage or mechanical forces, exposing to subenthelial collagen and necrotic plaque contents to the blood. So there is platelet aggregation, adherence, and are activated, releasing thromboxane A2, ADP, and serotonin, which in turn causes activation of coagulation by exposure of tissue factor and other mechanisms. Within minutes, the thrombus is evolved and completely occlude the artery.
Yes, great. Thank you. Okay, we mentioned 4 differences. Okay, how does myocardial infarction could develop in this patient?
Yes, myocardial infarction can occur within minutes if there is a vascular obstruction. So the aerobic state will be activated, and this will lead to drop in ATP and accumulation of lactic acid. This will lead to a rapid loss of contractility, and ischemia can occur. This is the early. These are early changes reversible, but if it takes more than 20 to 40 minutes, it can cause irreversible myocardial infarction or myocyte damage.
Yes, great. Thank you very much.
Thank you very much.
This is the end of our station. You did well. Thank you. Just revise the question you didn't remember, but
Yes.
overall, Very well, thank you.
Okay, thank you.
Dr. Salah, any comments?
No, this session came once only since long time, and no updates except.
Okay, great. So now we have Menam, Al-Shami, and Rami. Raise your hands, please. Guys, please, I need more to participate. So, Rami.
عندك عمرو وعندك منصور واحمد علي.
هما raising hands دلوقتي. طيب، اوكي.
عمرو من الاول، عمرو من بدري، وكان رفع معاه كمان مين؟ منصور دخل ولا ما دخلش؟
دخل.
يبقى احمد علي.
طيب ندخل احمد علي.
نضال، ومعانا نضال كمان.
طيب ماشي، حاضر.
انا معاك اهو، يلا انا معاك.
احمد علي. نضال.
السلام عليكم.
هي نضال كده اوكي، كانت داخله في الاخر بس يعني ماشي اوكي. اوكي. وعليكم السلام ورحمه الله وبركاته. Okay, are you ready?
Yes, Dr. Murad.
Yes.
Hello.
Hello.
Assalamu alaikum.
وعليكم السلام ورحمة الله. نضال, how are you?
I'm fine. How are you?
Are you happy now?
I'm sorry for interruption.
She was fighting with me.
I'm sorry.
Okay. She was questioning my organizational skills. Okay, so now we have a 65-year-old male patient with poor urine stream, urgency, and nocturia. PR examination revealed an enlarged, firm, rounded prostate with a preserved median sulcus. Okay?
Yes.
Okay, so Nidal, answer. What is the most probable diagnosis?
Yes, most probable diagnosis, it is could be benign prostatic hyperplasia.
Okay, so you did PR to this patient. So what are the features that may suggest a prostate cancer?
Yes, it is the hard nodular fixation in the rectal wall. Also, there is the obliterated in medial sulcus.
Yes.
Yeah.
Yes.
Median sulcus.
Yes, great. And the reverse means that it's benign. It's rounded, it's regular, with preserved median sulcus and not fixed to the mobile.
Yeah.
Okay, Ahmed, mention 3 investigations to be performed in the outpatient clinic.
Midstream urine, culture and sensitivity, PSA.
What else? You said 2. Midstream urine, it's 1.
Yes.
So we have 1 else.
Urine culture, renal function.
Of course, anyone with enlarged prostate, you need to check for back pressure changes. Okay, great. So what's the most important investigation to confirm or to exclude malignancy?
Transrectal ultrasound, guided biopsy.
So you do a trus biopsy. Perfect. So can you tell me how it's done?
It's done through a needle inserted into the rectum, guided by the transrectal ultrasound, and we get the samples from different sites.
Like tell me
12 core biopsies.
At least 10, but there may be 10, 12, 18. So don't mention numbers.
Okay.
But you take multiple biopsies, okay, from the mid loop, from the mid gland, and from the base.
Parasagittal.
Yes. Okay. But you're right, we take either 10, 12, 16, 18, but don't mention, okay. Unless asked, okay, why there is a need for multiple biopsies to diagnose prostate cancer? Answer, Nidal.
Because prostatic cancer, it is the multifocal or foci. You need to take multifocal biopsy.
Yes, because it's a multifocal disease, so you need to take biopsies from different areas of the gland. And you can mention, if you like, if he asked it, kept asking, you have the other answers in the book, but this is the perfect answer.
Yeah.
Okay, so biopsy showed high-grade prostatic neoplastic tissue admixed with rectal glandular tissue. How can prostatic cells be differentiated from rectal cells during pathological analysis? Ahmed.
Through immunohistochemistry for prostatic specific antigen and carcinoembryonic antigen to differentiate between prostate and rectal.
So in case of rectal cells, it will be negative for prostatic specific antigen and positive for...
Yes, rectal cancer will be negative for PSA and positive for
Not
CEA.
rectal cancer. They mean that during a biopsy, you have taken some rectal, you do it transrectal, so you have taken some rectal cells, so you need to differentiate.
Yes, okay.
Okay, so prostatic cells will be positive for BSA, while rectal cells will be positive for carcinoembryonic, will be negative for BSA.
Yes.
Okay, so next question. We said why, okay, how to differentiate. Okay, so what are the gene mutations involved in the pathogenesis of prostate cancer?
Yes, MSH, MLH, also TBRS2.
Yes, great. It's called transmembrane protease serine 2. Okay, great. Patient underwent URP for prostate cancer and 6 months later PSA was raised. What does this signify?
Signify recurrence of the tumor.
Yes, because after surgery, it is supposed to drop to
be
much?
Zero.
Yes.
Zero.
Yes, great. Thank you. Why BSA is, do you think it's a reliable needle?
Not specific for cancer because it is the significant for disease in the prostate at general, like any infection or inflammation.
Yes, it's organ specific, you mean, right?
Organism, yes.
Yes.
Can increase in state of any disease in the organ, but not specific for the cancer itself.
So what are the other causes that may cause it to increase?
Like prostatitis.
Yes, prostatitis, benign prostate hyperplasia itself, instrumentation, even after ejaculation. Okay, so it is not reliable. So
yes,
what is the name? Great. So, Ahmed, do you know the Gleason system?
Actually, the Gleason system is it's a score for grading of prostate cancer, and it depending on the architecture of the prostatic tissue. We take Gleason, the first predominant granular pattern, and the second predominant granular pattern, and with each other,
we add them together. Yes,
add them together to form the Gleason sum.
Yes, so it gives a number from what is the
number,
highest. The highest will be the Gleason. The highest Gleason will be
10.
10. Yes, and the best will be
1.
2.
Sorry,
there is no 1.
2.
Okay.
2.
So
yes.
we give a number from 1 to 5 for each of the 2 highest, most predominant. Yes. Then we add them together. So great. So just a question: what is the staging system for the prostate cancer?
ENM staging system.
Yes, great. So great. This is only grading. Perfect.
Yes.
So if a patient with prostate cancer developed back pain and CT showed increased density in the lumbar spine, what's your suspected diagnosis?
This is mets to the lumbar vertebra, and this is sclerotic mets, sclerotic bone lesion.
Okay, so what is the laboratory test to exclude bony metastasis before doing this?
Alkaline phosphatase.
Yes. Okay. So you said what is the expected type of metastasis in prostate cancer? Ahmed?
Type of metastasis in the bone
Yes.
is sclerotic bone metastasis.
Yes. انت مستغرب ليه؟
انا افتكرت المود اوف metastasis.
Okay, and why it would be sclerotic?
Because it's increase in the osteoblasts, I think.
Yes, increased osteoblastic
Increase in the
activity causing
activity.
Yes, more new growth
cause-
formation. Thank you. Okay, post TURP, the patient developed fever, confusion, dysuria, and dusky red urine. Why?
Could be UTI, urinary tract infection.
Yes. Okay. Which investigations would you request for this patient?
Laboratory like inflammatory CBC, inflammatory marker, urine, also urine general and urine cytology.
Yes, great. Okay. What's
urine
the
culture?
Yes, she said urine test. She said it.
Yes.
So what's the colonies number? Okay, in urine analysis indicating sepsis.
More than 10 power 3. More than 10 power 3.
Yes, 10,000. Yes.
10,000.
Yes, 10,000. Yes. At up to 10, it's normal, 10,000. But to say that there is sepsis, more than 100,000 actually. Okay. The 1,000 written in the book, or Dr. Salah said, it's a different thing actually. But it's not wrong, but it's not the number of colonies. I think it's a number of leukocytes, pus cells, something like this. Okay. So which of the blood components would rise?
In this neutrophil.
Yes, neutrophils. Okay. So what's the primary stimulus of prostate growth during life?
The androgen, testosterone.
Yes. In the past, bilateral orchidectomy was used as a treatment for cancer prostate. What was the rationale behind that?
This is for androgen deprivation.
Deprivation, yes, right. Okay. Can you tell me more? Why it's important to deprive the tumor of androgen?
Because the growth of the gland, prostatic gland, depends to androgen, specific testosterone. This is for growth of prostate and increase in size.
Okay, great. Thank you very much. You did very great.
You.
Thank you. Thank you. This is the end of our station. Dr. Salah, any comments?
No, this is taken from the checklist also, and all answers from the checklist. Also, since long time not, so keep in your mind. Yalla, next.
Okay. So next, we have Omar Al-Jassim and Ahmed Ali. So we have Ahmed Ali already. So Omar. Amr. Okay, you have Amr اهو. حلو جدا. Who else? Nidal joined. Okay, maybe Yasmin بقى. We can take Yasmin again. Okay. Yasmin. Okay. Okay, are you ready?
Yes, Dr. Murad.
I like this ثقة. A young female was cycling when she suddenly developed pain in her thigh. As soon as she put her foot on the ground, X-ray was done, showed fracture shaft femur with a hypodense shadow. Okay, so first question, what's the type of this fracture?
Pathological.
Yes, depending on this mechanism. Okay, pathological fracture. So what's a pathological fracture?
It is a bone fracture without adequate trauma caused by a pre-existing pathological bone disease.
Okay, great. So what's what are the causes of a pathological fracture?
Osteomyelitis, osteoporosis, osteomalacia.
Classify.
Neoplastic, non-neoplastic.
Yes, neoplastic like, and then
like
the neoplastic.
Multiple myeloma, osteosarcoma.
Again, neoplastic, classify primary and metastatic. I am sorry to interrupt, but this is important. Classify neoplastic, primary, you said multiple myeloma, and secondary, which are metastatic. Okay, non-neoplastic like
osteomalacia, osteoporosis, osteogenesis imperfecta, Paget disease,
yes,
bone cyst.
yes. Great, and radiotherapy. Perfect. So what are the most common primary sites for bone metastasis?
Lung, breast, prostate, kidneys, thyroid.
Yes, and the most common, if you يعني عايز تبقى exact, it's the prostate, then the breast. These are the most common, followed by the kidney, lung, and thyroid. But the most common of all is the prostate. Perfect. Okay. Great. So what is the name of brain tumor that may cause sclerotic metastasis?
Tubular sclerosis.
Sorry?
Tubular sclerosis.
Tubular sclerosis is a benign lesion that may cause sclerotic metastasis. Yes, you're right. But the brain tumor, it would be medulloblastoma. Okay?
Mm-hmm.
So the benign one is tuberous sclerosis, I'm sorry, and the malignant is medulloblastoma. So fracture was treated with internal fixation. How, during the internal fixation, how would you check for malignancy?
By taking bone biopsy.
Yes, great. Next question. Pathology results from the biopsy show the typical bland appearance, follicular cells. What is the probable location of the primary?
Follicular thyroid carcinoma.
Yes. So you mean the thyroid gland? Yes. So a thyroid nodule was detected and FNA was done. However, it has not been able to rule out or confirm cancer. Why?
Because the cytology could be the sample is inappropriate, or as carcinoma or adenoma must have capsular invasion or vascular invasion, which couldn't be detected by cytology and need the histology specimen to be detected in it.
Yes, so even the normal cytology, it's adequate and everything, but it wouldn't detect capsular or vascular invasion. Okay. So what are the other sites of ectopic thyroid tissue other than head, neck, and the mediastinum?
Ovarian and testicular teratoma.
Okay. Okay, great. Which investigation can be done to confirm thyroid metastasis?
Radioactive iodine scan.
Okay. And which type of thyroid cancer that will show no response to iodine uptake?
Medullary thyroid carcinoma, as it arises from parafollicular C cells and not from the follicular cells itself.
Yes, great. So the patient needed blood transfusion during surgery. What needs to be tested before doing a transfusion?
ABO and RH cross-matching.
Okay. If the patient blood group is known, would you still need to do cross-matching?
Yes, to detect any preformed antibodies in the patient's serum, which can cross-react with the donor's antigen RBCs on the RBCs.
Yes, great. So can you please tell me what are the complications of incompatible blood transfusion?
Immune hemolytic anemia, acute hemolytic anemia, febrile non-hemolytic anemia, the early complication and late complication. Early complication like anaphylactic shock, and late complication like electrolyte disturbance, hyperkalemia, hypocalcemia, hypothermia, early complication. And
Yes, so you can classify acute or late or early, or you can classify them into immunologic or non-immunologic, whatever one you like. Yeah, both are right. Okay. So can you please define hemolysis? You said acute hemolytic anemia. What is the definition of hemolysis?
It is the lysis of RBCs and release of its contents into the surrounding, which is plasma.
Okay, thank you very much. This is the end of the station. You did great. Dr. Salah.
This station came in Asia since a long time. Before my exam, I get it. Came once. This before my exam. Since I went for exam 2017, this station not came. So now you have about 6 years. Okay.
Mm-hmm.
Okay, great. So next we have now Saroj Kumar and M. Noor Bella. Okay, so raise your hands, please, if you want to join. Okay, so we have Mansoor again. So Mustafa, okay. Muhammad Rifat didn't join before, so we can take Muhammad Rifat. This one, I bet, who's okay, we can take him or her. Okay, so are you ready? Hello, wa alaikum salam.
Yes, I'm ready.
Okay, you are, and you are
Mahmoud Rifat.
Mahmoud Rifat. So there is anyone else joining? Mahmoud Rifat. Okay, sorry, Mahmoud, we need another one. Okay. Guys, if there is anyone else ready to join, we can
Yes, sir.
take. Okay, welcome. Okay, so now we can start. So a known hepatitis C patient suffered a traumatic splenic rupture with massive blood loss. A splenectomy was done and the patient received a massive blood transfusion. Later, the patient developed epistaxis, bleeding in the nasogastric tube and oozing from the surgical wound. Investigations showed severe thrombocytopenia and low fibrinogen with increased fibrin degradation products. So, our first question, what's your most probable diagnosis?
I think the IC.
Okay, why do you think that?
Because we have a thrombocytopenia and load increasing D dimer, decreasing fibrinogen, and increasing prothrombin time and partial thrombin time.
Yes, and bleeding.
Bleeding.
Yes, and a history of massive blood transfusion. So, can you please define BIC?
It is disseminated intravascular coagulopathy. It is a consumptive coagulopathy due to activation of both fibrinolytic and the coagulation system, leading to consumptive of coagulation factors and leading to widespread hemorrhage with destruction and decreasing of the platelets.
Yes.
And the microthrombi in multiple organs.
Yes, there will be microthrombosis. This is very important. Okay. Okay, how would you correct this DIC?
I can give a prothrombin complex concentrate, plasma, fresh frozen plasma, and cryoprecipitate, and also vitamin K.
So you
and
will give
transfusion.
you can give blood, you can give platelets, fresh frozen plasma, cryoprecipitate. Okay. So can you tell me what's massive transfusion protocol?
It is replacing of whole blood, whole circulating blood in the patient within 24 hours, or replacing more than 50% of the patient blood within 4 hours. It have complications like hyperkalemia, hypocalcemia, and volume overload, cardiac failure, acute hemolytic reaction, graft versus host disease, and also you can have acute respiratory, acute lung injury.
Transfusion related lung injury. So we have volume overload, we have electrolyte disturbances, as you said, hyperkalemia and hypocalcemia, we have coagulopathy. Okay, but okay. I just want to add something in the definition of massive transfusion. please, the most recent definition is a transfusion of 4 units or more within 1 hour or 10 units within 24 hours. This is very important because this is the most recent one.
Okay.
Okay. So how to minimize the need for blood transfusion?
With using hypotensive technique and warming the patient, and we can use cell scavenge and also good hemostasis.
Okay, so this is the operative measures to minimize blood loss. Yes, you are right, but pre-operative, we can also, yes, improve the hemoglobin level, give the patient
Correct
hematinics.
anemia. Okay.
Yes, to correct the anemia, and then
Central
during,
level for blood transfusion.
yes, so organize them. Pre-operative, as I told you, we correct the anemia. Operative, we minimize the blood loss by the measures you said. And if bleeding occurs, we can also use colloids, and then we will consider the level at which blood transfusion is considered. Okay.
Okay.
So how can you please tell me how platelets are formed and what's its shelf life?
I think from megakaryocytes.
Okay.
And shift
By
life.
fragmentation.
Okay.
And shelf life?
5 days.
Yes. Okay. Next question. Okay. Can you please tell me what is the percentage of platelets and white blood cells impact the RBCs?
Platelet are 0 and white blood cells is 5 multiplied by 10 power 6 or power 5. The leukocytic reduction RBCs.
Yeah, yes, you mean leuko-reduced. Okay. Can you tell me what the lifespan of RBCs?
120 days.
Okay, great. What would you tell the hematologist before giving the blood?
You will tell him the...
Actually, I don't like this question a lot. I think what the hematologist would do himself before giving the patient blood.
He will do ABO and RH and group cross matching.
Yes. Okay, you said cross matching. What do you mean by cross matching?
Cross matching is the testing of the recipient serum against the donor cells to exclude any performed antibody reaction.
Okay, which may cause hemolysis of the donor RBCs. Okay, so when we are doing this, which antigens are we testing?
ABO.
Okay, great. And RH.
And RH, okay.
Okay, so why does this patient has bleeding tendency in the first place?
Because they have a cirrhosis liver that will affect the vitamin K dependent senses of the coagulation factor 10, 9, 7, and 2.
Yes. Okay, so
and he also has a DIC.
Yes, of course. Why does this patient, sorry, what are the late manifestations of hepatitis C virus? It was mentioned in the stem that the patient has hepatitis C. Can you tell me what are the real manifestations of hepatitis C?
Yes, we have a late manifestation like cirrhosis and hepatocellular carcinoma, and we have a portal hypertension that can cause hematemesis and bleeding.
Yes.
We have
all the symptoms of liver cell failure. Yes. Okay, thank you. What activates intrinsic and extrinsic pathways of coagulation?
Intrinsic, which activate by the tissue injury, and extrinsic pathway.
Sorry, again, the intrinsic is activated by what?
Tissue factor?
No. It's intrinsic.
Endothelial injury?
Yes.
Okay.
So there will be endothelial injury will start by activating the 12 factor or Hagman factor. Okay, so and how can we test the intrinsic pathway?
By postponement time, activated partial postponement time.
Yes, and the extrinsic pathway is activated by
Thromboplastin, which released from damaged cells.
yes, tissue factor. It's the same as thromboplastin. Okay.
Okay.
So and how we test for it?
Postponement time.
Yes. Great. So okay, can you the patient developed after receiving a blood transfusion a hypersensitivity reaction. Can you please tell me the definition of hypersensitivity in general?
I think it's a reaction in the body leading to develop a symptom. I didn't know exactly.
Yes, it's exaggerated immune reaction of the body, okay, of the host in general in response to antigen or allergen, okay. Can you please tell me the different types of hypersensitivity reactions?
Okay, we have type 1, type 2, type 3, type 4, type 5. Type 1 is anaphylactic shock. Type 2 anaphylactic. Type 2 is cytotoxic. Type 3 is immunocomplex. Type 4 is delay type. We have a type 5, like occur in Graves' disease and myasthenia gravis.
Stimulating, you mean the one with the stimulating autoantibodies, like in autoimmune diseases, Graves and okay. So as you mentioned, right? And you have to know examples for each one and the mechanism. Okay. Great. So next question. The patient has sustained a long bone fracture. Can you mention different stages of bone healing?
First, we have a hematoma formation. Then we have a hypercartilaginous callus formation. Then we have a bone callus, and the end we have a bone remodeling and resolution.
Yes, great, thank you. What are the effects of prolonged immobility on bone healing?
We can have a loss of bone density and increased risk of osteoporosis.
Yes, so the bone mass will decrease, okay, because of the decrease in the gravitational forces, and this will cause demineralization of bone, okay? This is more elaborated answer, yeah, but I think Dr. Salah shared it before. Okay, so a fracture was treated by open reduction and internal fixation, then the wound started oozing yellow fluid. What's the first test to be done on this fluid?
Culture sensitivity.
Yes, we will do a wound swab for culture and sensitivity. Great. So wound swab and culture revealed BVL. What does BVL stand for?
Serbanton Valentini Cosidin. There's a X toxin, which is it's a cytotoxin. It will cause increasing virulence of the Staphylococcus aureus, and it will cause destruction of the membrane, like in hemorrhagic pneumonia.
So this effect, yes, you said all right, but just mention that it causes pores, because it's pore-forming cytotoxin. Okay. Yes, great. What would you like to do with the implant now, and why?
I want to remove it because it has a septic focus and
yes,
can have a biofilm that can be loose, not function.
Yes, yes, great. You mentioned the biofilm. Yes, great. Thank you very much. This is the end of our station. Dr. Salah?
Yes.
Do you have any comments?
Yes, I have some updates. First, for blood transfusion, I shared for you.
Yes, immunologic and non-immunologic. Yes.
Complication and how to reduce risk of blood transfusion reaction. So we discussed it before yesterday. about the complications of blood transfusion, it will be divided into immunological, non-immunological, and don't forget to add also about infectious, like hepatitis B and C from the complications. This is number one. Number two, how to reduce blood transfusion reaction. This question asked also. I shared the paper from David Lewis' book, and also written or collected by Nobel. يعني الكتاب ده معاك طبعا.
I'm the only one.
الكتاب ده لما اقابلك في مصر هاخده منك، كنت بجيب نسخه تانية. هاخده منك.
حاضر هصوره لك، ده اخر نسخه. This
لا
was the last one.
شوف نسخه ثانيه هاخده منك لما اقابلك.
ما يغلاش عليك.
بس انا معايا متصور، فانا عايز الاقي الاصل يعني. ذكي، خليك في اللي انت فيه، الكتاب اللي تاخده. انتوا بتذاكروا كلمتين والسلام، تذاكر مراجعه ليه؟ طيب. How to reduce the risk of blood transfusion pre-operative, intraoperative. Pre-op, consider the level of which blood products be required. يعني when you should transfuse. First, when hemoglobin less than 8, platelets less than 10, this pre-op. Intra-op, avoid blood loss by diathermy, maintain normothermia, and plus anti-fibrinolytic agent like tranexamic acid. Okay. Don't forget also the autologous transfusion. Okay. This regarding of the question of blood transfusion. By the way, this is the previous station, the stem, it changed recently. The بشوي كان في شهر 3 باين لي. I can't remember month 3 in care or something. The stem، ارجع للستيم الثاني كده. This is the last station by the way. ارجع للستيشن اللي قبلها كده رقم 11. The stem.
حاضر. لا we have another station by the way.
بعد مش 12 لجنه؟
ما دي كانت 11. you mean the next one is the last one? Yes.
Okay. The stem of this station changed, not like this way. It says that the patient has key wires for fixation, then the wound started oozing yellowish fluid. Many, they are thinking this will be osteomyelitis. Okay, because starting of osteomyelitis by this way. But the station is the same, this one. I think the stem discussing about hepatitis C also, and the patient needs blood, something like that. So the station started by one test you will do to this discharge. It will be culture and sensitivity. If the culture shows BVL, what this means? What is the BVL? Oh, here. لا ارجع تاني السطر اللي قبله، الصفحه اللي قبله. Okay, here. يعني start culture was started by ORA. Yes. What is the first test you will do? Then what is the BVL? Then what is the effect of BVL? Stages, how to manage the patient, stages of bone healing, like we discussed exactly what you will do to the implant, طبعا removal. They asked also in this session, I don't know when, why we use formalin for samples in general.
انا عندي answer للموضوع ده.
Okay.
هو بيقول
effect of immobilization for this patient on calcium level. On calcium level, effect of immobilization for calcium will increase it, by the way, will increase it.
لان هيحصل demineralization للبون عشان هتزيد، هيحصل relative increase في الاوستيوكلاستيك activity. And why we use formalin؟ هما الانسر ان هما دايما بيقولوا to preserve the sample.
Okay.
To fix، هي fixing، بس هي بتعمل fixation للسامبل، يعني هي fixing agent.
Okay, fixation and preserving the sample. Effect of immobilization also asked in this station. Okay. تمام كده يا شباب؟
Okay.
يلا.
Last station we.
This station, by the way, came for the last time, first time and last time in Cairo before Corona. This station of Maria. Acute pancreatitis in pathology.
Okay.
يلا.
So we have Nidal again عشان بس ما تبقاش زعلانة. Okay, and we have I guess Sarah. Sarah. Saruj is here, so he can participate. Okay. Good evening.
Good evening, sir.
Are you ready?
Yes, sir.
Yes, ready.
Yes. Okay. I'm sorry. I can't wait. Okay. So we have a 50-year-old patient complaining of epigastric pain with recent history of hospitalization for acute pancreatitis 4 weeks ago. Okay. Okay. So can you please tell me what's amylase and what's its function?
Amylase is a group of protein found in the saliva and pancreatic juice.
Yes. So can you tell me what's the function of it?
The function of amylase is it convert a glycoside, all are glycoside hydrolase, and act on alpha-1,4 glycosidase bound to convert the starch into the small carbohydrate molecule.
Yes. Thank you.
Oligo,
So what?
oligo and monosaccharide.
Yes, yes. It breaks starches to less complex, which are oligo and disaccharides. Okay.
Yeah.
But he said the whole idea نضال يعني ما تبقيش.
Yeah.
Okay. So زي. So can you please tell me what's CRB and from where it's produced?
Yes, CRB, it is the C-reactive protein. It is produced from the liver in the acute inflammation, acute phase of the inflammation.
Okay, so is it specific to any disease?
Not specific for any disease, but general indicates there is inflammation in the body.
And it's used to follow the progression and the flaring of the disease. This is very important.
Yes.
We use it.
Yeah.
Okay, so this patient was suspected pancreatitis. Which blood tests would you request?
Serum amylase, lipase, LDH, WBC count, and CRP.
Okay, thank you. So, and what biochemical tests would you do?
Calcium level, ABG, and also
And what do you expect the calcium level to be in this patient?
will be high in this patient. Also ABG.
Calcium
also,
will be high in this patient with pancreatitis?
This pancreatitis. No, calcium will be low.
So that's why I'm asking you suddenly. So you're
Yes.
not very bad. So what else? You said calcium?
ABG.
Yes.
Also lactate dehydrogenase.
He said it, one of the blood tests. We do also electrolytes.
Yes, electrolyte and
albumin. Yes, great.
Yeah.
Perfect. So the patient started complaining of epigastric fullness, dyspepsia, vomiting, low-grade fever. So what is the most probable cause based on the history?
Most probably he have suffered from the pseudocyst.
Okay, great. So most probably he developed a pseudocyst. Yes, that's right. Okay, so lab tests was, sorry, can't find it. Okay, so lab tests was done to the patient and it showed that hemoglobin level dropped. Can you please explain this?
Yes, could be rupture pseudoaneurysm due to this, also hemorrhage or bleeding.
Okay, so now we need to do definitive treatment for the patient. What are the options to stop bleeding?
Option of bleeding is to low molecular weight heparin.
The patient is bleeding. We need to stop bleeding.
No, yes, coiling.
Yes,
coiling, yes. Radiological intervention.
Okay, I'm trying to train you. Just listen to what I'm saying. You have a patient who has now bleeding hemorrhage, and you need to control this hemorrhage. How you would do it? What are the options?
Interventional calling.
Yes, I ask it with a different way. You can say I have a surgical option and a radiological interventional option.
Yeah.
This is any bleeding anyhow يعني in the abdomen. So what are the less invasive option? What is the less invasive option to stop the bleeding in this case?
Interventional radiology by calling.
Okay, so can you explain to me how does it work? How we do it?
Me or other answer for me?
Yes, you can answer, any of you.
This is use radiological intervention, introduce something like catheter
Yes.
inside the artery, and also there is induce foaming or any anticoagulant to decrease the blood supply, and also this is make incision or injury inside the artery, and this is the lead to activated intrinsic factor.
Yes, great. You have explained the idea. We use a catheter and the catheter releases a clotting agent, like you said, a coil or foam, and this will slow the blood vessel, cause injury, and this will activate the intrinsic system. Yes, great. So you said which part of the coagulation cascade will be activated? You said the intrinsic pathway. Can you please tell me, not you بقى, but what are the factors involved in the intrinsic pathway?
12, 11, 19.
So, sorry, again, you said 12, 11, and what else?
12, 11, 9, 10.
9, you mean 9. 10 is not in the
It's common,
intrinsic.
yes. It's common.
Okay, so we have 10, we have, sorry, 12, 11, and 9. Okay, great. This was a very short station, but you did it well. Thank you very much. And this was our last station.
Thank you, Dr.
Salah, you're welcome, Dr. Salah.
بقلل يومك لجنتين، انت هتيجي بعد 3 ساعات هم بيفصلوا، فمش هنعرف نكمل كده. انا عارف ان الموك معاك كويس جدا وهم عاجبهم الطريقه ديت. The best thing for this MOOC for today that Dr. Rod is confirming for the right answer. We should confirm for Suzanne and Maria to do like this way because some sent for me about this issue. I know it's very important. It will take time like you see. Yeah, we finished from 3 hours here, 4 hours. And it's very difficult, by the way, to revise it again. But anyhow, this is so informative mock. Thanks for all of you.
Thank you, Dr. Salah. I'm sorry يعني ان انا طولت عليكم, but يعني we tried our best, and next time يعني we'll do it faster. But يعني
لا الطريقه كويسه, بس المشكله بجد
ما هو بقى المشكله ان انت بتقعد تتعلم ان لازم تريبيت ذا انسر تو بارافريز عشان يبقوا متاكدين من الاجابه.
لا هو كويس, بس هو المشكله 4 ساعات هيفصلهم, بس ده القصه كلها.
اوكي. انا نفسي.
Let me tell you some points after finishing.